in 2011, and also he got his HPE from College of Physicians and Surgeons Pakistan in 2018. He has a number of professional experience. In 1996 until 1997, he is a house officer in Sandeman Provincial Hospital, Quetta. Then in 2002, he is a postgraduate resident in oral and maxillofacial surgery, Mayo Hospital, Lahore. He is a dental surgeon, HQ Mustakhail, from 2009 until 2012. He is a demonstrator in Bolan Medical College, Quetta, from 2012 until 2015. He is a senior registrar in Bolan Medical College, Quetta, from 2015 until 2016. And from 2016 until now, he is an assistant professor in Bolan Medical College, Quetta, Pakistan. He also has a number of patents and publications, particularly on temporomandibular joint arthroplasty and also oral cancer. Okay. Dr. Fazal Datkakar will deliver his lecture or presentation for around 50 minutes. So please feel free to type your question in the chat box. And at the end of the session, we have allocated 10 minutes for discussion to answer all of your questions. Now, allow me to welcome Dr. Fazal. Dr. Fazal, are you ready to start your presentation?
Yes, ma'am, I am ready. Bismillah.
Good. Yes. You may start your presentation now. Thank you.
Can anybody listen me? Ma'am, are you listening?
Yeah, your voice is clear, but
May I
your
start my
yes,
lecture? Are you
sure.
people seeing my lecture?
Yes, you can start your lecture now.
Oh, thank you very much. Bismillahir Rahmanir Rahim. Welcome to everyone at my lecture here, and thank you very much for your invitations. You people know that the topic of my lecture is teaching strategies in medical sciences for the students, learner, and for the teachers. As you introduced me that I am Dr. Fazaldat Kakar. My degrees are BDS, FCPS, MCPS, HPE. Currently, I am working as an assistant professor in Bolan University of Medical and Health Sciences. Okay, hello. This is a preamble of my presentations. Learner of X and Y generations, teaching and learning strategies, old teaching strategies and new teaching strategies. We will make difference. We will elaborate it. Role of a medical teachers and teaching context, which is the essential parts of the teaching and the learning.
Okay, बोलो काका.
As a hello.
ये माउस किधर है काका? इतना यहाँ पे मीटिंग खोलो काका. एक मिनट काका.
ये स्क्रॉल होने नहीं कर रहा यार.
नहीं, स्क्रॉल की प्रॉब्लम नहीं है, इस वक्त माइक्रोफोन की प्रॉब्लम है काका.
और
Professor, we are listening you.
your Dhruv sir, are you listening me?
Yeah, we are listening you. It's okay.
As a medical teacher, sir, as a medical teacher, it should be our motto that I may not have given you the fish, but I have tried to teach you how to fish. This should be the motto, the manifesto of a medical teacher. After that quote, which is a famous quote of a Pakistani educationist, Professor Javed Iqbal, let's we start our topic. Teaching, medical teaching is a process. This is a definition which is made by Imam Ghazali 1000 years back. Imam Ghazali said in his books, Ayyahul Hulum, that teaching is a process among the teachers, the learner, I mean student, and the context. All these three things when combined, then a process of learning and teaching occur. Either it is from any other sphere of life the teaching is, or from the medical science. The need for the medical science teaching is a teacher, learner, and context. We in our next slides will try to explain this process. The first one is the X generation and Y generations. These two terminologies are new in medical sciences and it defines an era. For example, X generations are defined in medical educations, in medical research, that the people who were born before 1990 back to the beginning of the teaching of Aristotle, Plato, Socrates, and Hippocrates. It means that from 1990 back to the starting of the world, all these peoples, all these generations were classified in a X generation. In contrast, another terminology, Y generation, is introduced. The Y generations are the people classified who were born after 1990 up to the next generation change. It means after 1990, the people who were born after 1990 are all classified in a Y generations. Y generation and X generations, people have different learning and teaching strategies. What are these strategies? Let's further elaborate or explain it. X generation's teaching strategies. It means the people before 1919 were adopting these strategies. These strategies are also called the traditional strategies. It means these are old ones. What are these? A 6 point I have included here. What is this? It means that the previous strategies, the strategies of the X generations were teacher-centered. What is teacher-centered? It means everything was teachers. Teachers was standing at the scaffold and delivering his lectures for hours, for 50 minutes. All others are just silent listener. What was the second generation of the X generation strategy? Its X generation strategies, second point was that its learner, its students were passive learners. They remained silent. They remained inactive in the classroom, only just listening. to their teachers, to their topics. What was the third point? The third point of the X generation teaching strategies was that these peoples are confined to a discipline-based curricula. What is discipline-based curricula? Discipline-based curricula means that it has a subject with a few contents, with a few topics, and a book which was a separate entity having a very less relations with the other subjects and topics. Fourth, in their strategies of the X generation was they have learned on the hospital-based learning. It means that the people establish a big hospital in a province or a country and were devoted to these hospitals. It's although manage the patients, but its epidemiology research was highly affected because its catching area was very big, and the doctors does not understand that the patient has with what epidemiology or cause behind the disease or the pathology is. The fifth strategy of the X generation of the previous people of the old generation was uniform elective. It means that these are based on the wise men approach. One or two wise men or teachers come together, sit together and designed a curriculum for the whole peoples. It means stakeholders or the involved peoples are not properly represented in this curriculum. The sixth and the last strategy, which was adopted by X generations of the people before 1990, was apprenticeship approach. What is apprenticeship approach? It means it was without understanding the mechanism or the science behind, only a student just by observation learning its thing. For example, a mechanic when tightening is a nut bolt is a student or is learner just by observation learning these, okay, how to tighten a nut or how to untie it, but does not understand the science behind it. If we in contrast since the Y generation, we will see that the strategies, the learning strategies of the Y generations in medical sciences are different. The strategies of nowadays are changed. Once it was teacher centered. Now it has changed from a teacher centered to the student centered, because the very objective of every institution was that, okay, the student will learn within, but not the teachers. So the concentration or the point of center was changed from a teacher to student. The new generations or the strategies of the Y generation is the number one, student centered. It means that students are everything in these strategies. And second point, okay, its learning process is not passive. It is active learning process. A problem is presented to the students and students are actively involved. In our next slide, we will see the output of the passive learning and the active learning, where active learning have much more important and worthy as compared to the passive learning. In the third point of the Y generation teaching strategies are integrated curriculum. It means it was not a discipline based, not confined to a book or a content. It is integrated. It means it in itself and have a big relations and collaborations with the other subject as well. The fourth strategy in the Y generations of the nowadays people, of the modern peoples, are community-based learning. Why? We, the people of the X generations, were learning in the hospital-based learning, have hospital-based learning. The fifth, I will inshallah elaborate all these points in my coming slides, but here the fifth strategy which is adopted by the Y generations was elective with core. It means that all the stakeholders are involved in it. The students, the patients, the parents, the teachers, and the atmospheres. It means all are have their representations when they are designing their curriculum or any other planning. And the last one is the systematic curricula. It means it is not based on the apprenticeship, it is systematic. The students, the learner understand the scientific background of any events, not just by observing they are learning it. If we compare these two strategies, we will understand further it. What is these strategies? If we see the teacher directed image, only the teacher is standing at the scaffold and one-way traffic is there. The teacher is delivering its lecture and the students are just silent listener. If we will see in the teacher directed image, while in contrast of that, the learner directed is a different, in which the teacher is just a facilitator, just a guide. The students are in active contacts with the teachers, as well as among in between they are in contacts to discuss, to activate their knowledge, to exchange their knowledge. So the first of the traditionals and the Y generations, student centers and teacher centers have a difference and have effects in learning and teaching as well. The second point is the in our traditional approach, our listener, our learner are passive learners. If we look at the a study which was conducted by Edgar Dale and which has changed the trend from a traditional approaches to the modern approaches, you people will see at your screen that in passive learning, only it was a study conducted by the Edgar Dale. He studied the people's care. What was the percentage remain of in his memories after 2 weeks? He asked peoples of the passive learning and the active learning. The result was that they in the passive learning only 30 or 50% of learning remain in his memories after 2 weeks. While when the students are involved as the active participants, then 80 to 90% of the learning remain in his memories after 2 weeks. So the passive learner is always a weak learner. In contrast of that, the active learner is a very potential learner, and he has the ability to analyze, to define, to create, to evaluate his material which we understand or read. The passive learner just define or describe or enlist some things. If we see in our next slide, the same slide was repeated here with a quote of the Confucius. It means that the interactive learning is not the demand of today. In the age of Confucius, which is a 2,500-year back person of China, he says that when I see, I forget. When I hear, I remember. And when I do anything, I understand. It means the interactive learning have a matter for understanding. Otherwise, a person will forget or uh, not remembered its things. The same things are once again here repeated. Okay, if we learn at the top of the cone by reading, then 10% will remain in our memories after 2 weeks. It was Edgar Dale study which I have mentioned earlier. Second point is that when we learn by hearing some things, only 20% remain in our memories. If we learn by watching a movie, 50% of the contents remain in our memories. While in contrast, if we see in the active learning as a participation or a discussion in a talk, 70% of our memories remain active, or it is remain in our memories if we learn by participation or active learning. And learning by doing, the last point is the learning by doing. In that, 90% of our learning remain in our memories, which is a big percentage as compared to reading or hearing, which is only 10 or 20%. So the third point of the traditional strategies are the basic, discipline-based curriculum. What is discipline-based curriculum? As I mentioned earlier, it was subject-centered, means having a books, independent subjects, having a less relations with the other books. For example, physiology having a less relation with the anatomy. And the same is here when we are learning, it is a learning in fragmented, not as a whole learning. It is a fragmentation learning. We understand by physiology, if, for example, cardiovascular system, we just understand in physiology the function of cardiovascular systems, but not the structure and biochemistry of cardiovascular system. So here in discipline-based curriculum, the learning is in fragmented form. When there is a fragmented learning, then there is not a complete understanding. So we must take rote learning, repetitions, which are all of passive learnings, and having a less relevance and interest. When any learning have a less interest, then there is must necessary to be learned through rote learning or repetition. In contrast of that, the Y generation strategies of learning and teaching are very, very compiled, integrated. They have started from the first phase, all the three professional aspects. For example, they learn knowledge, cognitions, they learn skills, they learn attitudes, all are parallels from the very first year to second year, and gradually they are increasing their basics towards the clinicals. The peoples of the Y generations are very integrated in their curriculum, very collaborative in their curriculum, in their subjects. Their teachers are in cooperation. Their disciplines, ward and institutions are in cooperation and collaborations. So the people of the Y generations have a very comprehensive approach to the learning and teachings. The fourth point of the traditional approach is the hospital-based learning. We, the people of the old generation of the traditional approach, having a big hospitals in a province or in a district, and so the whole area was managed by these hospitals. In contrast to hospital-based learning, which is a traditional approach, the Y generation's people are based on the community-based learning. They go to the community hospitals and they understand the cause, the epidemiology of the diseases. While in hospital-based learning, we are just managing our patients without understanding their cause, their epidemiology. When we are in community-based centers, community-based hospitals, we are fully understand the epidemiology, the cause, the prevalence, and can prevent these diseases at their very start. The fifth point, the traditional approach was uniform electives. It means a few, 2 or 3 teachers or wise men set together and design a curriculum for a generations or for generations. So the stakeholders are not representing in this curriculums. The traditional approach was to the curricula was a wise man approach. In contrast of that, the Y generations or the spice model have a elective with course. All stakeholders are participants in designing up their curriculum of their college academic activities, of their topics. They are with a co-representation. They are with a co-representations in between designing such type of activities. Last topics in the traditional approach is an apprenticeship approach. Apprenticeships mean learning just by observations of your teachers, does not understanding the science behind. So in our traditional approach, our learning was based on the apprenticeship approach. In contrast of that, the Y generation's people are very systematic in his approach. They understand the science behind it. When we understand the strategies of our learning teachings, our learning and teachings, the next steps after the strategies are the role of a teacher, of a medical teachers, which is divided according to the AMI guide into a 12 main important roles. The first 6 important roles of a medical teacher is: first, he is a facilitator. To facilitate is a learner in learning, one, and second, to mentor the activities of his learner, of his students. The second points of a medical teacher's, the role of a medical teacher is a role model for his students, where in the classroom as well as in his OPD in hospitals. His role, his character must be a role model for the students, for the learner. The third points, the role of a medical teacher is an information providers. Where information providers? In lecture hall, when he was with students, he become a lecturer, he given a lectures, then he become an information provider. The same information was provided in the clinical setups, in the OPD, in the hospitals. The fourth point of a medical teacher as a role model is a resource developers. It means he guide his students when he present a problem. He also given the resources to the students to understand the problems. So it should be in a study guide level or in a resources of the materials which he provided to the students. The fifth and the important role of a medical teacher in a medical college or hospital as a planner, to plan the curriculum, what was included in a medical curriculum and what was not included. The same, he is a organizers of the course, and the topics, he gives the priorities to the topics, which one is start first and which one is start later. The last and the most important role of the medical teacher is a assessor. Assessor of what? Assessor of students, to take exams from the students, to test the students that what was the level he is able to be promoted to the next class or wait for such promotions. And the second point, as assessors, he is a curriculum evaluators. He looks into the curriculums, the objectives which was designed for the curriculum, which was fit for the curriculums. Are the curriculums giving such objectives or not? The teaching strategies, the role of a medical teachers, and the third point in a learning and teaching process is a context. If you look into pictures, it was pictures from the history, the subcontinent, India and Pakistan. Once the teaching was in this process under a tree, the teacher was sitting and his disciples or his students are listening him and trying to understand what he was saying. But this is a picture from the history. Nowadays, the pictures of the X generation class is that which has started from sitting up a tree and in a circle around its teachers to a proper class, a sitting area, teachers, blackboard, chalk, and a flowchart, etc. These are all the developments which has started from a shadow of a tree till that class in which the blackboard and the chalks are present. But this is not so much impressive context. The context of the Y generations of today's students, you can see a smart class in which every person has his laptop, the teacher has phone, and the students have a different pages to open to understand a problem. Not necessarily a book, a defined book or a defined page is necessary for this. No, every students have their own approach to understand a problem and trying to find the text or the resources of the problems from a different sides. So in the end, I will add and say that for the three most important integrated elements of the learning teaching is as strategies of learning and teaching, which is different in the traditional era. In the X generations, it was not so impressive, but in the Y generations, by research, it has proven it has too much effective for learning and teachings. The same is the role of the medical teachers, and the context, the institutions, the atmosphere of the classroom have a matter. So when you have a smart classroom, a role model teachers, and a research proven strategies for learning and teachings, I am sure the very good learning and teachings is occurred in a medical institutions. Thank you very much, everyone.
Thank you so much, Dr.
This
Fazal.
is the references. If anyone have any questions are welcomed in this regard.
Okay, thank you so much for your delightful lecture, Dr. Fazal. Now we are in the discussion session for about
Yes,
10,
welcome.
yes, for about 10 minutes. Maybe from participants, anyone would like to ask a question to Dr. Fazal? We are welcome to discuss anything about teaching and learning. Okay, maybe I have some question. Can I share screen, Dr. Fazal? Could you please stop sharing your PowerPoint presentation?
Yes, ma'am. Thank you.
Okay, thank you, Dr. Fazal. I will try to share my screen to show you a question. Maybe from this question, we can start the discussion about teaching and learning.
ये मैं मन का ये कैसे बात कर
यहाँ से एक मिनट पुलिस समझाते कि
Okay. Dr. Fazal, as we know, maybe, yes, as we know, maybe everyone, our students have different learning styles. Some of them maybe have like, they will understand if he read a book or study guidelines or something else. But others might find it easier if they listen the lecture, or maybe some of them also prefer to actively engage in activity to do some experiment or activity to understand about the content of the lecture. So our students may have different learning style, right? So how can we, as a teacher, can facilitate the different learning style among our students? Dr. Fazal? Dr. Fazal, is it clear, my voice and question? Yes. Is it
Are you
clear?
listening, ma'am?
Yeah, is it clear
It
for the
is clear.
question?
Madam, are you listening me?
Yes, I can hear your voice clearly.
Yes, ma'am. The answer of your question is that okay, we have five senses by which we are learning. If
Mhm.
we involve only one sense, for example, the seeing or hearing sense was involved, then it has a 20% our learning occurred. While we involved our all five senses, learning, taste, listening, and touch, all were involved. The Edgar Dale study showed, and this study have changed the trend in the medical learning and teaching. So it means that when we involve all our five senses and in interactive study, in interactive sessions, we involve all five senses, then the learning occur very impressively as compared to involving one or two sense. In lecture hall, we are just involved our hearing sense or listening sense or seeing sense, okay, to see the blackboard. Only two sense of our sense organs are involved in this. When in contrast of that, we involve all our five sense, which I have mentioned in interactive study, all these are involved. So in Edgar Dale research, you have seen that only in the first to one, only 20 or 30% learning is occur, while in interactive study, 80 to 19% of the learning is occurred. It means that interactive is much better, three times better than a passive learner.
Okay, maybe it will be related to our second question. So, how can we encourage our students to actively engage in learning?
Ma'am, it is as I mentioned, it is not a single tip process. Three big elements are involved. First, teacher. Second, student. Third, the context. If we are trying to improve our learning or our teachings, we will focus all these three aspects of atmosphere, of context, of the teachers. We will focus our teachers to adopt the new research and the new strategies for learning and teaching. And the same we encourage our students for the learning process, which is proven by research that it is productive, not by traditional approaches. Although the traditional approach or the traditional generation still resisting the new approaches, they are adapt to the old ones, so they resist. In our institutions still today, they are resisting the new approaches, the Y generations approaches. So it has time taking, number one, and multifactorials. We will address the all aspects of this process, from teacher to context, from context to curriculum, from curriculum to the learning and teachings and strategies. So all these are the these need to focus our by solving their problems.
Okay, maybe we face a number of barrier or challenge during the current pandemic of COVID-19 because we have to deliver a lecture mostly online using Zoom platform. And some of us uh, feel that it's very difficult to engage students in learning using online platform, using Zoom, because some of them maybe just turn off the video, or maybe when we ask them any questions and no one asks us question, and we when we would like to follow up to make sure whether they understand or not with our lecture, no one ask question for us. So how how can we keep in touch, or how can we encourage them to more actively engage in learning, particularly using online learning strategies? Is there any recommended online teaching and learning strategies?
Yes, ma'am, it is a new development of the online learning and teaching, and a good development it is. Inshallah, it will show its effects in the near futures. But it is new, especially in the backward developing countries or backward areas where not such basic necessities are available. So we hope for good in futures. Okay, the interest of the students, which is not so much impressive nowadays on online learning, with the availability of the facilities and the encouragements of the teachers and the parents, I am very hopeful that inshallah the future will be in the process of learning and teaching in online. Yani the online learning and teaching will contribute a lot in near futures to our learners as well as to our teachers, hopefully.
Okay, how about in Bolan University, Dr. Fazal?
How, ma'am?
How about in Bolan University, in your university, how you deliver a lecture to your students at the moment?
We are here in our in Balochistan, in Quetta. Nowadays, the pandemic a little bit situation is improved, so our colleges and university are reopened for the classes, and we have started our lectures in our classrooms. Earlier, we are on online lectures or online learning and teachings. Nowadays, from the last 2 weeks, here the situations of the pandemic corona was very improved, and we here the authorities have decided to reopen their institutions, and the classes of the lectures of the students have started once again.
Okay, how is the preparation of the offline lecture after the pandemic era?
Ma'am, in the pandemic area, the teachers have a much time because they are free from so many activities, and we have developed a number of our lectures on the multimedias from the different resources and have shared with our students on online. But you know and you understand that face-to-face discussions on a topic is much worthy than a online, because in online learning teachings, you see some the other end sometimes is just present at the screen but not involved in the process of learning and teachings. The face-to-face learning and teaching process is much worthy and effective as compared to online. But if there is no other options with you in such a situation like the pandemic of corona, then you have the only option, and that is the online class learning and teaching.
Okay, I also see in your slide before there's like a community-based learning. Is it, isn't it?
Yes.
Yep. How is how you how we can implement, or how we can run community-based learning during this current situation during pandemic era like now?
Ma'am, if we look into the big hospital setups, there is a crowd always because it has a big catching area. If we see a big hospital's catching area, its patient, the crowds of the patients, The community-based hospitals is better because it only entertain a limited community in this area. So the crowd is not present always there. A small town or a small community was entertained by a community-based hospitals, and this has an importance and advantages that the epidemiology, the cause, the origins of any disease, of any pathology, you can find very easily in the community-based hospitals or community-based learning teachings. While when a big hospital was there and it has a big crowd and not the peoples are identified from which area these persons have come, then the epidemiology, the causes of the diseases, of the pathologies are not easily understood. So the Y generations prefer to be to the community based because of the culture, of the understanding, of the mental level, of the finance, socio-economic status of the people, and they learn this thing. Okay, when poor socio-economic background persons, how to deal them, how to understand them, how to teach them, how to manage them. So this is a very core point, very fundamental points. Okay, we have started from the community based, and community based have much learning potentials than big hospitals or hospital based learning. So not only the current research suggests that the learning of the post graduation and the learning of the graduation must be on a community based to understand the custom, culture, socio-economic status, mental level, and financial levels of your patients.
Yes, I agree with you. It's important to learn to have community-based learning because we have, if we want to solve a health problem, we have to understand about the root causes of the health problem in the community. To do that, we have to approach the community and learn from them. I agree with that. But the challenge we face during the pandemic of COVID-19 currently, at the moment, uh, we cannot approach the community because we can't touch them during this pandemic era. So how do you think we should stop community-based learning at the moment, or what do you think?
Ma'am, as I mentioned, okay, the effects of pandemic was now not so much effective or so much risky. Its effects was listened here, but you are right. Okay, it is a very difficult job, okay, to entertain your patients from the OPD. So here in Quetta, we in this pandemic area take the supports of the online medicines, and our consultants, especially the pulmonologists who are treating the pandemic patients, the corona patients, they have starting online medicines to their students, to their patients, and the same was in the community based. Earlier, it was closed from the authority sides, that all the hospitals and the educational institutions were closed for a specified period. Now it is open, but the precautions online as well as the hygienic precautions in the OPD were adopted. So it was the strategies were here changed for treating or managing a patient. Gloves and mask and the sanitizers, all these are the blessing of pandemic. You understand?
Okay, thank you, Dr. Fazal. Maybe I would like to greet our head of dental public health department, Prof. Titi Bernianti.
Ma'am, I don't understand what you are saying.
Yeah, I just would like to greet our head of dental public health department in Faculty of Dental Medicine. Maybe he have a question to ask to you. But
Please.
I think Prof. Titi Bernianti has another agenda maybe. So I think I also see here our second speaker is already here. So I think that will be the last question for our first session of Stovit Online Seminar series this morning. So also this is the end of our session with Dr. Fazal. Thank you, Dr. Fazal. It's very
Thank
interesting
you
to
very much,
hear.
ma'am.
Yes, it's very
Welcome.
interesting to hear about your presentation. Thank you so much for sharing your knowledge with us. Hope to see you again next time. Thank
Inshallah.
you for all
Thank
the
you,
part.
ma'am. Thank you
Yes,
very
yes.
much.
You're
Okay, bye.
welcome.
Thank you.
Thank you for all the participants too. I will hand over to MC to lead to the next agenda. Dr. Ratna.
Thank you, Dr. Dini. Now may I request Dr. Andra Rizkiawan, Dr. Gigi PhD, Spesialis Bedah Mulut dan Maxillofacial, to give certificate as an appreciation to our first speaker today, Dr. Fazal Kakar, PDS, FCPS, MCPS. Dr.
Yes, thank
Andra.
you very much. Yes, thank you very much, Dr. Ratna. In this session, I would like to give a certificate of appreciation as a lecturer in a Stovit online series to Dr. Fazal Kakar, PDS, MCPS, HPE, and FCPS as a speaker. Thank you very much for Dr. Fazal for your nice and interesting presentation. We hope we can see you, we can meet you in Surabaya, Indonesia. Thank you very much, Dr. Fazal.
Thank you, Dr. Andra, and also Dr. Fazal for your amazing presentation. We hope we can meet again in the future. So, ladies and gentlemen, in this second session, we have Dr. Nizam Baharom from Public Health Faculty of Medicine and Health Sciences, University Science Islam Malaysia. He will talk about outbreak investigation. And in this session, we will be moderated by Dr. Dini Setiawati, MPH, PhD. Dr. Dini, time is yours.
Thank you, Dr. Ratna. Before we start with our second speaker, I forgot to give a summary about the first session of Stovit online seminar series today. From Dr. Fazal, I would like to give a summary of his lecture this morning. So, to sum up, as a medical teacher, we should not give the fish or the knowledge, but we have to teach how to fish or how to gain knowledge to our students. And the process of learning is among teacher, learners, and also context. Based on the presentation from Dr. Fazal, the student will remember 90% of what they learn if they say and they do. So we should change from the traditional approach of learning to the active learning. Okay, we move to the second session of this Stovit online seminar series. Okay, hello everyone. We meet again, and I'm still assigned as the moderator for the second session of our today's Stovit online seminar series. Thank you for all participants who joined us from the first session and still stay with us until now. I would like to welcome to all participants who just joined with us. Now we are in the second session of Stovit online seminar series today. Let me introduce myself again. My name is Dini, and I'm a lecturer in Dental Public Health Department, Faculty of Dental Medicine, Universitas Airlangga. And I will be the moderator for the second session of Stovit online seminar series today. In the second session of today's Stovit online seminar series, we have Dr. Nizam bin Baharom from University Sains Islam Malaysia as our speakers who will talk about outbreak investigation. That's a very interesting topic, isn't it? as it's really relevant with our condition right now. So I think in that Department of Dental Public Health, there are a lot of lectures that have a similar research interest. Maybe we should have a joint research collaboration later on. And before we start the second session, I would like to welcome our speaker, Dr. Nizam bin Baharam. Good morning, Dr. Nizam.
Good morning. Assalamualaikum. Selamat siang. Can you guys hear me?
Yes, it's clear. Waalaikumsalam warahmatullahi wabarakatuh. It's still morning in Indonesia, Dr. Nizam. What time is in Malaysia?
I think we are 1 hour
Ahead.
we are 1 hour behind you.
Oh, behind me. Okay.
Yeah. So it's 10:30 here.
Oh, now in Indonesia it's 9:30. So you are 1 hour ahead from us. Okay.
Yeah, 1 hour ahead.
Yes. Okay, nice to see you here, Dr. Nizam.
You too.
Yeah.
Thank you, Dr. Dini.
Now allow me to briefly read his curriculum vitae before he starts his presentation.
Sorry?
Yeah, I will read your curriculum vitae first before you start.
Oh, I see. All right. Okay. Thank you.
Okay. Our second speaker, hang on. Okay. Our second speaker is Dr. Nizam bin Baharam. He is a head of Department of Primary Healthcare, Faculty of Medicine and Health Sciences, University Sains Islam Malaysia. And Dr. Nizam got his MBBS from St. George Hospital Medical School, London in 2002. Then in 2010, he got his Master of Public Health from University Kebangsaan Malaysia. And then in 2015, he got Doctor of Public Health degree from University Kebangsaan Malaysia. His research interest is around tobacco use and vape in Malaysia, and also on non-communicable diseases, especially diabetes mellitus, epidemiology, and biostatistics. His research interest, I think, your research interest is similar with our staff in the Department of Dental Public Health, Dr. Nizam.
That's good to know. Maybe we can collaborate.
Sure, later on we will have a future research collaboration. Okay, Dr. Nizam also has a number of grants and publications. He currently has 5 ongoing research grants and also a great deal number of publications. Okay. In the next 50 minutes, Dr. Nizam will present a topic about outbreak investigation. So please feel free to type your questions in the chat box. We have allocated 10 minutes to answer and discuss your question at the end of the second session. Okay, Dr. Nizam, are you ready to start your presentation?
Yes, let me just share the screen.
Okay, good. You may start your presentation now, Dr. Nizam. Thank you.
Can you guys see the screen, my PowerPoint?
Yes, yes, you see the screen.
All right. Okay, Bismillahirrahmanirrahim. First of all, I would like to thank the Fakultas Kedokteran Gigi from University Airlangga and University Hasanuddin for inviting me into this series. I think it's a wonderful job that you guys done. I've looked that you've had this series for quite a while, and it's very popular and among students and also internationally because it's on YouTube. So thank you very much for inviting me. It's good to know, Dr. Dini, that we have similar interests. So maybe we can collaborate on research and so forth. So today, I'd like to talk about more about sharing about outbreak investigation and management. Okay, so this is the outline of my session. And so we'll see, we'll talk about some epidemiology key terms and then review about surveillance for infectious diseases. And then we look at why we do outbreak or epidemic investigation. And then what are the steps involved in doing epidemic investigation and management. Then we also look at the roles of oral healthcare providers or professionals, OHCPs, in outbreak management. Okay, right. So I presume that majority of the audience are dental students. Am I correct?
Yes.
So, right. So this will be like a revision for the students. So let me just remind us all what is the key terms in epidemiology. So we have epidemic, which is also often termed as outbreak. So the term epidemic and outbreak are quite interchangeable. When you talk about outbreak, you're talking about epidemic. So what is epidemic? Epidemic is when disease occurrence among a population in a given geographical area that is in excess of what is expected at a given time and place. So what defines in excess? So that depends on the organism or the diseases that's involved. So different outbreaks or different epidemics with different organisms have different definitions of what is in excess. And so to define what is in excess, you need a lot of local data. You need a lot of you need guidelines from the Ministry of Health so that you can define, are we in epidemic or not, or are we in outbreak or not. Otherwise, you might just have clusters. So clusters are a group of cases in specific time and places. There might be more than expected. So clusters could be an epidemic, or it could be just pure coincidence, which is not enough to be an epidemic. An endemic is when the disease or the condition of interest is present among the population at all times. For example, dengue is present in most localities in Southeast Asia at all times. So dengue is endemic. And when dengue exceeds the threshold for outbreak, then you would declare an outbreak of dengue. Otherwise, it will be called endemic. So things like in certain places, cholera, typhoid, even influenza is considered as endemic. So when do you declare pandemic? Pandemic is when the disease has spread across several regions. So there are several definitions. Some say it has to cross at least 5 WHO regions, or it has to across many continents for you to declare the disease of interest to be called pandemic. So at the moment when the COVID-19 started in Wuhan, China, was only epidemic in Wuhan, and then it became epidemic in China. Then when it crosses many regions and throughout the world, it is declared as pandemic. And what is public health emergency of international concern, or PHEIC? It is defined as extraordinary event which constitutes of a public health risk. It has to be a public health risk. So it could be infectious disease or any other health events. Public health risk to other states through international spread of disease and potentially requires a coordinated international response. So that will be declared by the WHO. Like when WHO declared Ebola PHEIC in 2018, so there's a set of criteria that WHO has to go through before they can declare that this is a public health of international concern. Right. So this is an epi curve or epidemic curve. So when the disease is present at all time, the term used is endemic, such as dengue or cholera or typhoid in certain places. So it depends on the geographical area of definition of what is an outbreak. However, there is a threshold that the number of cases have to go beyond that threshold before you can declare an outbreak or an epidemic has occurred. For example, influenza is endemic in your area. You have like 1 to 10 cases, depending on your geographical area and the definition of what is the number of cases for threshold. Then beyond that threshold, when you suddenly get seasonal epidemic, then you would declare epidemic or outbreak of influenza in the area. Okay, let's have a look at surveillance or infectious disease surveillance. So surveillance is very important is part of outbreak management. It can also be part of ongoing infectious disease management. So surveillance is an ongoing systematic collection of data, collation, analysis, and interpretation. So it's not just enough to just collect the data, but you do not know how to interpret the data that's presented in front of you. And then you have to disseminate the information to those who need to know in order that action can be taken. So in summary, surveillance of infectious disease is really data or information for you to take action on, for you to decide whether you have to provide additional intervention, or you have to review your current health programs, whether it's adequate or not in terms of containing the infectious disease. So surveillance data are definitely crucial for monitoring the health status of the population, detecting diseases, and triggering action to prevent further illness and to contain public health problems. So I'm sure we are all familiar with some disease surveillance or have some examples or experience in infectious disease surveillance. And there are two main types of disease surveillance. Is either indicator-based or event-based. So indicator-based have a routine setup or formal reporting of diseases or syndromes from within the healthcare system. So there's notification forms, and there is an online notification system and so forth. So these will be done for routine infectious or common infectious diseases. What's also equally important is the event-based surveillance. So event-based surveillance is organized and rapid capture of information, which could be rumors, it could be unsubstantial or ad hoc reports about events that are potential risk to public health. For example, suddenly you receive information from the veterinary department that a bunch of chicken that suddenly got sick and died. And that could trigger event-based surveillance, for example. Okay, so examples of indicator-based surveillance include notifiable disease surveillance systems. That's the ongoing routine surveillance system for common infectious diseases. Sentinel type surveillance. So sentinel type surveillance, you don't get notification from all the healthcare services, but you choose sentinels. For example, you choose maybe 10% of the number of hospitals or clinics to become your sentinel for information. For example, when you do influenza-like illnesses, you don't get information from every clinic. You get information from just certain clinics that become your guard or your sentinel clinics or hospitals. So for you to receive information and to monitor the data and to decide whether an epidemic or non-epidemic has occurred. It can also be from lab-based surveillance. So not everything is from disease notification. It can also be from lab results. It can also be from formal reports from healthcare activities. Event-based surveillance include mass media reporting. It can be just rumors reporting, public complaints, government agencies reports, especially from the non-health agencies, and also from NGOs. Okay, so this is Dr. Li from Wuhan, China. He was one of the early doctors that noticed there's some unusual presentation of influenza in Wuhan, and which did not quite fit in with the influenza-like illness surveillance. So what he did was a combination of indicator-based surveillance, but did not quite fit in, and it's also event-based surveillance. So he was one of the earlier doctors that try to warn the health authorities that perhaps impending SARS he was thinking about SARS-1. So he was thinking there could be an impending or re-emerging of SARS outbreak. Unfortunately, he's one of the victims of COVID-19. Okay, this is a typical notification form from the Ministry of Health Malaysia. So you often tie this with the national law or local law so that it becomes compulsory for health practitioners to notify the system. And failure to notify or to do so will result in some form of penalty. So for example, in your dental practice, if you see hand, foot, and mouth disease, for example, it's under disease number 16. So if you fail to notify the local health authority regarding the hand, foot, mouth disease case, so it becomes it's an offense that which could be penalized. Yeah? So I'm sure there's a similar law regarding disease notification in Indonesia. Okay, so nowadays we moved on to e-notification. So previously there was a lot of forms and a lot of handwritten forms, and the information comes very late. But nowadays with the IT, Internet of Everything, so e-notification is a norm, and the data, the abundance of data becomes very fast and a lot. So there's room, there's a need for public health, medical or dental professions in currently and also in the near future. Okay, so revision on epidemiological triad. So why do epidemics occur? So basically you have the equilibrium between the host, the agent, and the environment. But anything that upsets the equilibrium, for example, anything that increases the ability of the agent or the bacteria or the virus or the infectious organism to infect the host will trigger an epidemic. For example, during the third wave of COVID-19 with the co-variants of SARS-CoV-2, so we saw increased rate of infection. Yeah? So that would be an example of increased ability of the agent, or it could be the increased susceptibility of the host. Or it may not be anything to do with the host or the agents, it's just the environment that shifts towards the favoring, increasing the ability of the agent or the host. For example, during flood time, you will see a lot of food poisoning, a lot of food and waterborne diseases because the environment has changed. So, for example, increases in travel where individuals travel to areas where infectious disease exists. For example, during Olympic 2016, if I'm not mistaken, there was a lot of concern about Zika virus and Zika outbreak. Increased interactions between human and animals. Malaysia had issues with Nipah virus outbreak. Contamination of food, water, or vehicles by agents that not normally present. Pre-existing infections occurs in endemic area and reaches susceptible persons. For example, measles, where in pockets where immunization is not, coverage is not very good, so you could introduce a measles outbreak there. Yeah, or host susceptibility and response are modified by naturally or drug-induced immunosuppression. Okay, so why do you conduct epidemic investigations? Basically, number one is to implement public health control and to implement prevention measures. But equally important, or sometimes number two is more important, is to address the public, political, or legal concerns. And then number three is to consider health program development or evaluation. It can also be as part of research opportunities regarding the disease, or it could be also for training of the healthcare staff. Okay, Of course, the main important objective of doing epidemic or outbreak investigation is to implement public health control and to prevent further outbreaks. So basically, you want to contain the outbreak by identifying and eliminating the source. And then once you eliminate the source, you should be able to stop the progression of the transmission and the outbreak in general. So prevention measures must also try to halt any future potential outbreaks within the same or nearby communities. And control of spread of communicable disease reduces unnecessary disease morbidity and mortality. Of course, the overall objective is to save life and to prevent morbidities. But we live in a society, yeah? So sometimes the action on epidemic investigation is because of public outcry or political noise or legal concerns. And so sometimes, remember during the Zika outbreak, post-Olympic 2016, Zika didn't actually cause many cases or mortalities. There were a lot more infectious outbreaks that requires attention apart from Zika. But however, there was huge public outcry and public concerns, and the political leaders were worried. So the attention and the resources and the forces are all attended towards Zika disease, but there was no outbreak at all. Yeah? So what I'm trying to say is sometimes what we do is also to address public concern and political concerns. All right, so we do outbreak investigation because there are certain health programs that are already in place. And why these health programs are there to prevent outbreaks or to minimize the risk of outbreak. So perhaps when there is an outbreak, we need to re-evaluate whether these health programs that are in place, whether they are sufficient enough, or whether do they need any renewing or re-evaluation so that the program can become better in terms of what it is supposed to be, which is to prevent outbreak in the first place. All right, so of course, with emerging diseases such as when COVID-19 first came out, there was a lot of opportunities for research. We need a lot of information about what are the causative agents, what was the mode of transmission, how long was the incubation period, what's the clinical spectrum. Even now with the cold variants, we are still doing all this and trying to find a lot of data and information. So there's a lot of opportunities for research in outbreak investigation as well. Okay, so part of outbreak investigation is also for training of the staff. So you train for the outbreak preparedness and you see how well do they handle the outbreak. So healthcare staff could develop the following skills through practice and experience, such as diplomacy, logical thinking, problem-solving ability, quantitative skills, epidemiologic know-how, and clinical judgment. Okay, what are the steps in outbreak investigation? So WHO call it steps, but when you think about steps, you think about one, you do one, and then you do two, and then you do three, and then you do four, right? So that's why it's called steps, right? You step one at a time. But in outbreak investigation, these are like the pillars of outbreak investigation, but the steps are not necessarily done in sequence, in such sequence. For example, when you arrive and in outbreak locality, you may want to start implement control measures, for example, separating the sick and then those who are not ill, right? Or start doing the sanitation and so forth. So even though these are called steps, I want students to realize that these steps are more like pillars of outbreak investigation, they're essential, but in real field work, it does not happen in that sequence. Okay? So step 1 is preparedness. Step 2 is establish the existence of an outbreak. Step 3 is to verify the diagnosis. Step 4 is to define and identify cases in the outbreak. And step 5, to perform descriptive epidemiology. Step 6 is develop hypotheses. And step 7 is to evaluate and confirm them. And step 8 is to execute any additional studies. Step 9, implement control and prevention measures. And step 10 is to communicate your findings. Okay, preparedness. So preparedness should be done way before any outbreak occurs. Yeah? So you need to identify who do you have in your team should an outbreak occur. Do you have any public health consultants? Do you have any epidemiologists? Your health inspectors? You have enough paramedics and assistants and so forth. And so you need to also identify a place for command center, bilik gerakan, to coordinate investigation and to control all the outbreak investigation activities. You need to have a lot of training for your healthcare staff. You have to consider what are the training necessary should an outbreak occur so that the staff are ready for embracing any outbreak investigation. So you need to prepare also the guidelines or the manuals and all the equipment and supplies needed for an outbreak investigation. You also need to set aside some budget, or perhaps the transportation, and you also have to think about little things like duty rosters and food management and so forth. Okay, so the preparedness has to be done in advance, and there has to be some allocation of resources towards the preparedness. Okay, step 2, you have to establish, is there an outbreak or is there not? So you have to establish the existence of an outbreak. Now, when you look at the increase of number of cases, is it a true epidemic? Could it be just clusters? Does the observed number exceed the expected number of cases? If you go by the definition of threshold. So first of all, you need to define the threshold. You need to define the threshold by determining the expected number of cases for the area in the given time frame, especially for endemic diseases. So different locality may have different threshold, or you may want to follow your Ministry of Health guidelines for definition of certain outbreaks. So in excess, an excess of cases may not necessarily suggest an outbreak. It could be due to different reasons. For example, you change the way of local reporting, or changes in cases definition. For example, you change the body temperature definition from 38 degrees Celsius to 37.5. So when you lower the body temperature definition, you will get a lot of more cases included in such definition. So, or it could be just an increased awareness among the public. When you say TB, for example, when you do a health promotion campaign on TB, and then those people with prolonged cough should come for investigation. With such health promotion, you suddenly get increased number of suspected cases and confirmed cases of TB. It could be due to improvement in your diagnostic procedures. You probably get new PCR machines or new imaging machines, so that it improves your diagnostic procedures. Or because there's a new infectious disease control specialist in the hospital. So because of new procedure and SOP, more cases are identified. For example, MRSA cases in hospital. Or it could be sudden changes in the population size. So we see this often during Hari Raya or Idul Fitri, where suddenly the rural or the kampong has a lot more populations, and they bring with them their dengue virus and influenza and whatnot. So it could be due to that. Okay, so you need to establish, is there an outbreak or not? For notifiable disease, use health department surveillance record. For other diseases and conditions, find existing data locally such as hospital discharge records, hospital mortality statistics, cancer, or birth defects registries. In local data, if local data are not available, apply rates from your neighboring cities or neighboring what do you call it, provisions, yeah, or the national data, yeah, or alternatively, we can conduct a quick survey. Yeah. Finally, conduct a survey of the community to establish the actual data for the level of disease. Okay. Step 3 is to verify the diagnosis. So your goals in verifying the diagnosis are twofold. Number one is to ensure that the problem has been properly diagnosed, that it is really what has been reported to be. So Malaysia had this experience with what we thought was JE outbreak, Japanese encephalitis, in one of the states in Malaysia, but it turns out it was not. So verifying the diagnosis is very important. It turns out that the actual cause organism was Nipah virus. Secondly, the outbreaks involving infectious or toxic chemical agents, you must be certain that the increase of the diagnosed case is not the result of any mistakes. So you need to discuss with a lot of people, the infectious disease specialists or the lab people, your pathologists. You need to discuss with them. And then you need also to review the symptoms and the features of the illness and compare that with the laboratory results. And then you may want to visit and talk to people who became ill, then summarize the clinical symptoms findings with the frequency distribution. So all this may help you to really verify the diagnosis. Because this is an example of frequency distribution for food poisoning outbreak. Because after you verify the diagnosis, you need to set up the definition of cases. So case definition is a standard set of criteria for deciding whether an individual should be classified having that condition or not. So a lot of the times for common infectious diseases, we already have guidelines. So use the Ministry of Health guidelines where possible. A case definition is a standard set of criteria for the health condition, which includes the clinical criteria and also the epidemiologic information, time, place, and person. So apply them consistently without bias to all persons. Anybody who fits in with the criteria, you should consider them as cases. Never include in the exposure or the risk factors in the case definition. For example, case definition is people who has been to these certain places, which is the risk factor, for example, or people who has eaten this and this and this and this. That's not a good definition for case. So restrict the definition using signs and symptoms only. So we have several types of case definitions. You have suspected case. So suspected case is a case that meets the clinical case definition with the signs and symptoms. You also have confirmed case. Confirmed case is a case that has a laboratory confirmation, and also the epidemiological link to the outbreak. In the middle, sometimes you do use this, or sometimes you skip this definition. You also have probable case. So probable case is a case that meets clinical case definition and has supportive or presumptive laboratory results. For example, you have screening test kits. So if the actual confirmatory test takes a long time or a few days for you to get confirmation, sometimes we use screening tools or screening test kits, which is faster, that gives you results within minutes to hours. So we can use the results of presumptive lab results for the disease plus the symptoms or clinical case definition. So we can define them as probable cases. So I'll give you some examples. So For example, for measles, the clinical case definition is any person with fever, and the term "and" here is very important. So it can't be just fever or macular rash or cough and cold. So it has to be fever and rash and cough and cold symptoms. And so the definition, the terminology for clinical case definition is very important. And the lab criteria is if you have proven any IgM antibodies or if you could culture it. So if you have any confirmation of presence of measles virus, so that will be the lab criteria for measles. So the suspected case classification definition is anybody with the clinical symptoms. Confirmed cases is anybody with the lab confirmed results. So that's the example for measles. Examples for hand, foot, and mouth disease. So the clinical case is any child with ulcer, mouth or tongue ulcer, and rashes or vesicles. Rashes or vesicles, or with or without history of fever. And the lab criteria is if you're able to prove any Coxsackie virus or Enterovirus 71 virus, and so that will be the lab confirmation for HFMD. So very often we forego the lab criteria because majority of cases of HFMD, which were quite mild, and we do not proceed with the lab confirmation. But these clinical case definition and lab criteria are included in the suspected and confirmed definition of cases. Right, so step 4 also involves identifying and counting cases. So we can also do direct case findings at healthcare facilities where the diagnosis is likely to be made. So you've done your diagnosis and case definitions, and now you want to find the cases and identify the cases. So in some outbreaks, public health officials may decide to alert the public directly to make sure they are aware if there could be potential cases themselves. So you tell them what are the symptoms involved, what are the signs that they need to be wary about. Or you can do active or passive case detection, or you can do conduct a survey. Okay. Also, what's helpful during step 4 in defining and identifying cases is developing a line listing. So a line listing allows information about time, person, and place to be organized and reviewed quickly. There's also a good way to keep track of different categories of cases. So a typical line listing would have the date, and then the symptoms, whether they have it or not, and then any labs results and some demographic data. Okay. Step 5, once you have determined the diagnosis and the case definition and get your cases, you perform descriptive epidemiology. And so the basics of descriptive epidemiology is time, place, and person. So, so descriptive epidemiology alone, without any hypothetical testing or without any inferential statistics, and descriptive epidemiology alone provide a lot of evidence, a lot of information, comprehensive description about the outbreak. There's a lot you can learn just by looking at the descriptive epidemiology. So you can assess description of the outbreak to develop causal hypothesis. So you look at the trend over time, and the distribution by place, the distribution by person, and this helps you to develop hypotheses regarding the outbreak, regarding what is the sources, what is the mode of transmission, what are the risk factors involved, who are the populations affected, and so forth. Okay, so what do you do with time? So there's a lot of questions you can ask. Yeah, what is the exact period of the outbreak? What is the probable period of exposure? What is the probable incubation period? Yeah? What is the outbreak? Is the outbreak common source or propagated? Yeah? Propagated source and so forth. Place. What is the locality of the outbreak area? What kind of place? Yeah? Is it an institution? Is it within just an institution? Or is it in the community? Is it within a public setup or private organization and so forth? Yeah? What is the most significant geographical distribution of the cases and so forth? So, and person, you can get information about what kind of demographics are involved with the outbreak or epidemic. What is it involving children, young people, middle-aged persons, or the elderly, or all of them? Yeah. Is there any specific age attack rate or gender attack rates? Yeah? What are the age and gender groups at highest or lowest risk? Yeah? In what other ways do the characteristics of the cases differ from the general populations? Yeah? So it's quite fun doing public health during an outbreak because you get to think a lot. Yeah? Part of the difficulties is collecting and defining the data to collect. But once you get the data, there's a lot of thinking involved. There's a lot of reasoning and thinking and deductive involved in trying to pin out this information about the outbreak. Right, so we've seen examples of the epidemic curve. So epi curve is a visual display of the onset of illness among cases associated with an outbreak. And the epi curve is represented by a graph of X and Y. X is, of course, the date, yeah, or the date or time of illness. Yeah, so it depends on the outbreak. If it's a very rapid, short, acute outbreak, so you may not want to do the data by day or weeks. So you could do it by hours or by quarter or by PM, AM. Yeah, so it depends on the how acute is the outbreak. If the outbreak is long and like ongoing, such as pandemic, you could do it not by day, but you could do it by epidemic week or even month. Okay? And Y is the axis for number of cases. So each axis is divided into equal space intervals, although the intervals for X and Y may differ. So you can determine a lot from epidemic curve. Yeah? So for example, the time trend of the outbreak, the distribution of cases over time. Yeah? You learn that from doing the epidemic curve over time. Yeah? You get the general sense of the magnitude of the outbreak. Yeah? You get the sense of the direction of the magnitude. Is it going up or is it going down? Yeah? You can also see outliers or cases that stand apart from the overall pattern. Yeah? Could that case be the point source, yeah? or could that case be the index case? Yeah? You can get to infer about the outbreak pattern of transmission. Yeah? Is it common source? Is it propagated? Is it contact to contact transmission? Yeah? The most likely time of exposure, the most likely incubation period, and so forth. The magnitude can be assessed easily by a glance of the epidemic curve. Yeah? Are there many cases or just a few? Is it going up or is it going down? The time trend or the distribution of cases over time will give an indication of where the outbreak is in course. Are cases still rising or outbreak already peaked? Does it appear that the outbreak is over? How long has it been since the last case occurred? Outliers are cases that stand apart from other cases. Outliers include the index case, which might be the source of the outbreak, and cases that occur well after other cases, which might indicate secondary spread. of the illness. And so there's a lot of thinking to be done after you've done a good epidemic curve. Okay, so this is a general principle for counting attack rate. Yeah, so attack rate is basically the number of people exposed as the denominator, yeah? And then the numerator is the number of people with symptoms. So for example, in acute gastroenteritis outbreak, 75% of people attended the picnic, and then 46 got ill. Yeah, so what is the attack rate? The attack rate will be number of people with symptoms over number of people exposed. So from here you get 61%. Okay, so now step 6 is to develop hypothesis. So all aspects of the investigation should be addressed, including what is the source, yeah? What is the mode of transmission, what is the exposure that can cause the disease, yeah? Any additional information regarding time, place, person, and place. So from your descriptive epidemiology step, yeah, you start to think of this. So you develop hypotheses that you need to prove. Yeah? So consider what is the agent's usual reservoir, how is it usually transmitted, what vehicles are commonly implicated, what are the known risk factors, and so forth. Okay. So another useful way to generate hypothesis is to talk to the patients, yeah? And then to talk to the patient, and that gives you some idea about whether you're heading in the right direction or not. Okay, and then you have to evaluate the hypothesis by doing lab tests, yeah? Environmental tests, and then you can also do a quick study such as a case control study, or you can also do cohort study. Okay? So for example, a typical example in food poisoning outbreak, yeah? You do case control, yeah? Then the risk factor that you hypothesize is persons eating at this restaurant. And so from here, you can get the odds ratio, and that gives you the indication of the place or the source of the outbreak. Right. So step 8 is you may want to add additional studies to confirm or to refine your hypothesis. Step 9 is implementing control and preventive measures. So as I said before, even though this is called step 9, yeah, it's not necessarily one of the last steps to do. Yeah, so this is probably one of the first steps that you do. Yeah, but in terms of the pillar of outbreak investigation, this is under step 9. Yeah, so as you know, there are many ways to implement control measures. Yeah. You can do by reducing the susceptibility of the host. Yeah, the easiest way is to remove them from these from the exposure. Yeah, you can improve the immunity by immunization. Yeah, you can use chemoprophylaxis, sanitation is a good thing to do. Yeah, you do vector control measures if vectors are involved. Yeah, you can also enforce by law. Yeah, for example, you have several infectious disease law that requires the public to comply. And so certain things you need hard measures for control. Okay, the last step is communicate your finding. And so you can communicate your findings, yeah, so through writings, reports, online, and so forth. So this is a form of risk communication in public health. And so nowadays, risk communication is not one-way communication. For example, it's from health authorities to the public. Yeah, you have to know that risk communication is a two-way communication. You have the information regarding the outbreak. For example, you have the information regarding the potential organism involved, what are the risk factors that are involved, but you also have to listen to the concerns and the questions from the public. So their concerns and their concerns may not be the same as what is your concern regarding the outbreak. And so this communication has to be two ways. You have to listen to each other. And so who do you talk to? Of course, you have to talk to the relevant stakeholders, yeah, the local government, yeah, the local health workers, concerned authorities, the community and the community leaders, the regional health authorities and the ministry and so forth. The report is a record of performance and a document of potential legal issues. Yeah. The report is also a reference for the health department if it encounters a similar situation in the future. It is also a document that contributes to the knowledge base of epidemiology and public health. Okay, so post-epidemic action, you maintain the surveillance of the disease. Yeah. If it's under common routine surveillance, so you keep on doing that and perhaps improve the system. Yeah. And then you maintain the control measures, and the aim is to prevent another outbreak. Okay, this is the flow, epidemic management flow. So you can see within this flow, after verification that there is an outbreak, you immediately do the case control, the control measures, sorry. So immediately do control measures as well as starting the investigation. And even before that, you have to set up the operation room. And once the outbreak has finished, you can close the operation room. And so the data analysis that you do, that you get from the investigation helps the control measures as well, and all helps towards the cessation outbreak. And finally, you do your final documentation and report, and then you do your risk communication and publication if you want to. Okay, this is an example of a recent outbreak. This is the one that I can find of an outbreak that involves oral surgery practice. So this is kind of a event-based surveillance, yeah, where initially they have reports of 3 patients who got Enterococcus faecalis endocarditis after undergoing surgical procedure in the same practice. Yeah? So it triggers suspicion of an outbreak. So what they have done is do a retrospective surveillance. Yeah? So remind yourself of all the steps in outbreak investigation. So all the 10 steps of outbreak investigation are reflected in this abstract. Yeah, so they define, verify the diagnosis, yeah, which is Enterococcus faecalis, endocarditis, and then they define the case definition. What is the case definition? With the case definition, they go and identify cases by doing retrospective surveillance. Yeah? So they interviewed patients and they found further 15 cases with enterococcal endocarditis. Yeah? By using a standardized questionnaire. They also do environmental check, interview the staff, and review medical records. And then from then, they found that there were breaches of recommended infection prevention practice. So this is the cause or the source of transmission. Somebody was not doing infection prevention practices as the guidelines, yeah, during the procedure. Yeah, so that was identified as the potential source of transmission of enterococci. Yeah? And then they do the control measures and so forth. Yeah? So all the 10 steps of investigation, outbreak investigations are reflected within the management of this particular outbreak. So if you want to read more, you can find the outbreak from Ross et al. In Journal of American Dental Association, 2018. Okay, so let's talk about what are the roles of OHCPs in epidemic management. Yeah? So these roles of OHCP is relevant whether it is a small outbreak in one small institution or in a small local community or in a bigger district or provision, or in a national or even international or pandemic level. So the roles are still similar. So as a healthcare worker, the public sees you as the source of information, as the reliable source of information. So the OHCPs are also responsible to provide the public with reliable source of information, plus including the relevance into the dental practice as well. Yeah? So that's one way of the oral healthcare professionals or providers can contribute in epidemic management. If not, they can directly involve with the management of patients in outbreaks. They can be in the oral healthcare providers are trained to do many procedures. They can do the injectables, they can do the IV lines, they can do the prescriptions. So they can be directly involved with inpatient care or outpatient care or even on location of the outbreak. The dental settings can provide good logistics, which will help with the outbreak management. For example, you can provide syringes, needles, and medical equipment, and so forth. You can lend your BP set, you can lend your machines to help with the outbreak. Or I've seen many setups where they use dental clinics which has good negative pressure to minimize the contamination from aerosols from COVID-19 patients for doing swab, for example. So they've used dental clinics to run PCR swab on patients because it has good negative pressure in the room. So you could lend your logistics like that. And during this pandemic, I've actually worked alongside with many dentists in the screening area. They do come down and volunteer with the COVID-19 screening. They volunteer also with the vaccine center, at the vaccine center, because they are trained and licensed to do injections. So we can help out with the vaccine center and so forth, or with the administration. So there are actually many avenues for oral healthcare professions to help out with the epidemic management. All right. So the conclusion is the dental settings or the oral healthcare settings may not face many outbreaks in your own setup. However, you have to be prepared in case of an outbreak happening in the dental setting. So I think preparedness, being able to anticipate what to do, being trained in what to do if an outbreak occurs is very important. And if not, in the general outbreak management, the medical and the dental counterparts can work together alongside with no problem at all. I think we both can help each other in terms of general outbreak management. Okay, so I think that's the conclusion for today's sharing. And with that, I would like to say thank you very much.
Thank you for your insightful presentation, Dr. Nizam. Okay, now we are in the discussion session for about 10 minutes. And could you please stop sharing your PowerPoint presentation, Dr. Nizam?
Again?
Yes. So I can share my screen for our discussion. Sorry. Okay.
All right. How do you stop sharing? Oh yeah, got it.
All right. Okay, I will share my screen for our discussion today. Okay. I think there are several questions that we can discuss for this session. So the first question is about when COVID-19 was identified in Wuhan for the first time before it spread it out. Was it endemic or epidemic, Dr. Rinza?
Okay, good. The first question is when it was identified for the first time. It's not even endemic. For it to be endemic, that it has to be there all the time. So first
Okay.
of all, it was very difficult to diagnose to give the diagnosis of the new emerging outbreak.
Mhm.
So they thought it was SARS, the first SARS
Okay.
virus, but it was not that, and it was also not MERS-CoV. Yeah? So it was a new emerging virus. So any new emerging virus you cannot call it endemic. So it's actually a new epidemic, a new outbreak.
Okay. So I think it's relevant to the last question. Is the disease steady in endemic area? So in endemic area, this disease should be there for a long time, isn't it?
Yes.
Okay.
So there is a definition. You have to have definition for what you want to call as endemic. Yeah. So the definition involves number of cases for the threshold. So anything below that number of cases, if the disease is present or not, zero can also be a number. So if, for example, this month, 0 case, next month, 3 cases, another month, 1 case, the other month, 0 case. So as long as it's below the number of cases, the threshold for the number of cases, depending on the organism or depending on the outbreak, then you termed it as endemic. For example,
Okay.
cholera. So and as long as within that geographical area, it does not exceed the threshold for cholera, and whatever is defined for threshold for cholera for that geographical area. So in places that never has cholera before, so one is considered as a threshold. For example, in many countries which are rabies free, one case of rabies is considered as epidemic. So you cannot have an endemic of rabies. So endemic depends on the definition of the number of cases.
Oh, okay. But we also know a term of hyperendemic, I think.
Yeah, hyperendemic, holoendemic.
Yes.
Yeah.
Okay. Because our students sometimes they're confused about the definition of each term in
Yeah,
epidemiology. Yeah.
there are a lot of different terms, but I think for students, they need to master the key basic terms. I
Okay.
think
Yeah.
holoendemics involves a definition of age as well.
Yeah. I agree with you. The definition of key term, epidemiology key term is often used interchangeably.
Hmm.
Okay. And then the next question is, are epidemic and outbreak the same?
Mm,
It's common
yeah.
question from our students.
Yeah. So the correct clinical or health term is epidemic, but the term outbreak is interchangeably used because the public use the term outbreak. So if you want to be more specific, once it has reached the definition of epidemic, it is called epidemic. But in the media or in the public conversation, you may not use the term epidemic because they may not understand what is epidemic. So you use the term outbreak, but it is the same.
Okay.
But if you're talking in the formal report and if you're looking by definition, you should use the term epidemic.
Okay. So it depends on where the term is used, right?
Yeah, true.
And
Depends
the
on
audience, the audience of the.
betul.
Okay, all right. And for the next question, what is the difference between pandemic and public health of international concern?
Okay. They can be the same, but pandemic is by definition is when it crosses several continents. And so if it happens in Southeast Asia and then it goes to Middle East, then it goes to Americas and so forth, so you can term it pandemic. But public health emergency of international concern is more specific, and it has to be declared by WHO. So some of the definitions include it has to have international concern, and let me see, let me go back to the definition. Okay. The main difference is public health emergency of international concern requires coordinated international response. So that's for WHO to decide whether such, for example, when they declared Ebola in 2018, that that declaration is based on the fact that it requires coordinated international response in terms of border control and changes of data and information and so forth. So that's the main difference between PHEIC and pandemic. A pandemic can be like the umbrella term, and PHEIC is a more specific term under the umbrella of pandemic.
Okay, all right, that's clear now. And maybe the last question, in sentinel surveillance, the data is collected only from certain clinics. Is it for an endemic disease or epidemic disease?
Okay, very good question. So sentinel surveillance, the idea for sentinel surveillance is the disease the trend or the information regarding the disease can be captured from certain sources only. Can be clinic, it can be hospital. And the term sentinel is, the general definition of sentinel is guard, G-U-A-R-D, guarding the station guard, for example, sentinel. So the idea is you do not have to have routine data collection from every clinic or hospital, but you can monitor the trend of the data from just certain clinics. For example, clinics that has high risk or high population, to capture that data so that it reduces the burden of everybody doing the surveillance. So is it for an endemic or epidemic? It's actually for infectious disease. And so, yeah, so you may not have an actual endemic that already occur, but you may do, or the epidemic has not been reached, you have not crossed the threshold. So the surveillance is there, whether that's an endemic or whether it has reached epidemic or not. So the surveillance, the objective of the surveillance is to capture whether we have it or not. And if we have it, are we still under endemic, or have we gone above the threshold and declared epidemic?
Okay.
So within the surveillance, you could have from the sentinels could capture no case, or the sentinels do capture cases, but it's still within allowed number of cases to be called endemic, or from the collection of case data, you determine that there is an uptrend of number of cases, and we may have overgone the threshold, and we have to declare an epidemic.
Okay, I think that your answer is related to the very last question. What is the threshold value for epidemic? Yeah. Okay. Thank you so much, Dr. Nizam. I will stop share my screen first, and then I think we run out of time for our second session of today's Stovit online seminar series. Before we come to the end of our session with Dr. Nizam, let me to sum up the presentation of Dr. Nizam. So Dr. Nizam has already clarified the key term of epidemiology that is often used interchangeably: epidemic, outbreak, cluster, endemic, pandemic, and public health emergency of international concern. He also talked about epidemic occur because there is imbalance between host, agent, and environment in epidemiological triad. And then there are also 10 steps of outbreak investigations that is not necessarily done in a sequence. And the objective of outbreak investigation is to implement public health and preventive public health control and preventive measure, address public, political, or legal concern, consider health development programs or evaluation as research opportunity regarding the disease, and training for health care staff. So outbreak investigation and also surveillance data collection is crucial. And the last thing is about what our role as oral healthcare providers in epidemic management. So we can be a source of information, patient care management, to provide logistic to have the outbreaks, and also to volunteer, for example, in COVID-19 screening or in vaccine centers. Okay. Okay, that's the end of our session with Dr. Nizam. Thank you, Dr. Nizam. It's very interesting. Yes, it's very interesting to hear about your fruitful presentation. It gives us new knowledge and understanding for us, and hope to see you again next time. Thank you for all the participants. Stay safe, stay healthy, and have a good day. I will hand over to MC to lead the next agenda. You're still mute, Dr. Ratna.
Thank you, Dr. Dini, for leading this session. Up next, may I request Dr. Andra Rizkiawan, Dr. Gigi, PhD, Spesialis Bedah Mulut and Maxillofacial from Universitas Erlangga to give certificate of appreciation to our speaker today.
Yes, thank you very much, Dr. Ratna. I would like to give the certificate of appreciation to give a lecture in a Stovit online series. This certificate present to Dr. Nizam Baharom. Thank you very much, Dr. Nizam, for your lecture, the interesting and nice presentation. Thank you very much, Dr. Nizam.
Terima kasih, thank you.
Terima kasih, Dr. Nizam. Stay safe and stay healthy, Dr. Nizam.
Thank you, you all too.
Thank you.
Salam. Assalamualaikum.
Assalamualaikum warahmatullahi wabarakatuh.
Also, we would like to give certificate as an appreciation to our moderator, Dr. Dini Setiawati, MPH, PhD. Please, Dr. Andra.
Yes, thank you very much, Dr. Ratna. Dr. Dini, thank you very much.
You're welcome, Dr. Andra.
Dr. Dini, thank you very much.
You're welcome.
Thank you, Dr. Dini. And also thank you, Dr. Andra. Okay, ladies and gentlemen, we have come to our third session with Professor Masahiro Ikubo, DDS, PhD. He is from Dental Informatics and Radiology, Graduate School of Dentistry, Tohoku University. Today, he will talk about importance of dentomaxillofacial radiographic examination for the patient with systemic disease. And in this session, will be moderated by Dr. Ramadan Hardani Putra. I would like to introduce about our moderator in this section. Good. Okay. Dr. Ramadan finished his Doctor of Dental Surgery in 2012 and Master of Dental Health Science in 2015. His recent article is published in 2021 about current application and development of artificial intelligence for digital dental radiography. Hello, Dr. Ramadan.
Hello.
Okay, Dr. Ramadan, time is yours.
Okay. Thank you, Dr. Ratna, for your kind introduction. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all the participants and welcome to the third session of today's Stovit online series. So my name is Ramadan and I will be your moderator for this session. First of all, I would like to welcome our honorable speaker, Professor Masahiro Ikubo from Japan. Konnichiwa, Sensei.
Konnichiwa.
How are you today?
I'm fine.
Okay. Thank you for joining us today, and we are very pleased to have you here. Before we started the lecture, let me read his curriculum vitae first. Professor Masahiro Ikubo earned his DDS degree in 1994 from Tohoku University. And in 2004, he achieved his PhD degree also from Tohoku University Graduate School of Dentistry. And now he is a professor in Division of Dental Informatics and Radiology, Tohoku University. And he is also become a visiting lecturer in several universities in Japan, that is Nippon Dental University, Okayama University, and Fukuoka Dental College. Currently, he has been also appointed as a director of Division of Oral and Maxillofacial Radiology, and also as a director of perioperative oral health management in Tohoku University Hospital. He has numerous publications in international academic journal, books, and any other publication. He also has many experiences as a speaker in many conferences. And recently, in this past April, he was one of a keynote speaker in the International Congress of Dental and Maxillofacial Radiology that was held in South Korea. Today, he will share his valuable knowledge and experience about the importance of dental maxillofacial radiographic examination for the patient with systemic disease. The lecture will be presented in 50 minutes and followed by discussion section. And to Professor Ikubo, you may start your lecture now.
Okay. Okay, can you hear my voice? Okay.
Yes, it's clear, Sensei.
Okay. And can you see my slide? Okay. Slide okay?
Yes, I can also
Okay,
see
PowerPoint
your
okay?
slide. Okay.
Okay. Okay. Dr. Ramadan, thank you for your kind introduction. And good morning, Indonesia. My name is Masahiro Ikubo. I am the professor of the Division of Dental Informatics and Radiology at Tohoku University's Graduate School of Dentistry. Tohoku University Graduate School of Dentistry has a lot of foreign students from Indonesia, including, sorry, oh. Please. Okay, I'm sorry. including Dr. Ramadan. Oh. I'm Dr. Ramadan's chief reviewer of a PhD manuscript. He's an excellent student, and his research is very interesting. So I graciously accepted to be his chief reviewer. Furthermore, he asked me to speak at today's lecture. So I graciously accepted to be a lecturer. Today, I'm going to talk about the importance of dental maxillofacial radiographic examinations for patients with systemic diseases. The content of today's lecture concerns my lecture as a keynote speaker at the International Congress meeting held in May. The reason why I chose this content is because my role in our hospital collaborates between the medical and dental divisions. First, I'd like to introduce my working role in our hospital. Then, I'd like to share with you a few of my experiences with cases in which systemic and oral diseases have been closely related. After that, I'd like to introduce my basic research developed from such cases. I work at Tohoku University Hospital, located in Miyagi Prefecture. Tohoku University Hospital is one of the biggest hospitals in northern Japan. Everyone, do you know about the Great East Japan earthquake that happened 10 years ago? The magnitude of this earthquake was 9.1. The level was almost the same as the Sumatra earthquake. This map shows the seismic intensity of the earthquake. The pink circle was the most shaken area, followed by the red one, and this point shows the epicenter. As you can see, Miyagi Prefecture was the closest to the epicenter and the most shaken area in Japan. Our laboratory was destroyed by the earthquake. The bookshelf collapsed. The walls broke, and we could not enter the office for quite a while. In my apartment, the pipeline could not be used. I was unable to use the water service for over 2 weeks and the gas service for over a month. It was a very inconvenient time. Additionally, tsunami attacked our region, which caused extensive damage to the coastal area of our region. This resulted in over 12,000 deaths. Although the death toll was lower than the Sumatra earthquake, it was very shocking to me. Every day, we visited this area in order to perform autopsies and dental care with a feeling of great disappointment and also pride as dentists. During this time, we received many donations from foreign countries, including Indonesia. Again, I'd like to thank you for your support and encouragement from the bottom of my heart. And please provide your support and encouragement to me today as well. I was requested to provide an interesting and funny lecture by Dr. Ramadan, even though I cannot speak English well. This request was the greatest disaster in my life after the Great East Japan earthquake. That being said, I'd like to describe my working role in our hospital. I'm professor of the Division of Dental Informatics and Radiology The name of our division was changed from the oral diagnosis division last year. Additionally, I have been serving as the director of the Perioperative Oral Care Support Center for the past 4 years. We are performing radiographic readings such as computed tomography, abbreviated to CT, magnetic resonance imaging, abbreviated to MRI, ultrasound imaging, abbreviated to US, and nuclear medicine imaging. Oh, who is this? And writing report on the image findings of these modalities. Oh, who is this? As another function of a previous division, I also performed a medical interview and examination for all new patients who visited our hospital. Based on this information, I made a diagnosis. Furthermore, our division also provides oral medicine diagnosis and treatment. We examined patients with oral mucosal diseases, xerostomia, a taste disorder, and other related symptoms. So we have always acknowledged the relationship between oral diseases and systemic diseases. I treat oral diseases of a lot of patients with systemic diseases because Tohoku University Hospital is not separate from the medical and dental division. Hence, we have a strong collaboration with medical doctors. On one occasion, I got a lot of advice from medical doctors. For example, recovery is slow after surgery in patients with bad oral condition. I intubated the respiratory tract for the general anesthesia, and then the patient's tooth fell out. No. Mouth sore causes severe pain in patients with bad oral conditions during chemotherapy. Therefore, we established the Perioperative Oral Care Support Center. This center is for all patients whose stay in the hospital is due to systemic diseases. We have many patients who are waiting for surgical treatment because it is well known that undergoing dental treatment is very important before surgical operations. Recently, it was revealed that patients with good dental health can recover sooner from surgical operations and show better prognosis. Actually, the Japanese government recommends dental care before surgical operations, particularly for cancer, resulting in a perioperative dental care system that is covered by national health insurance in Japan. We perform medical interviews and examinations for such patients every day. Actually, we check and edit teeth, which may cause a problem before, during, and after the surgical operation. And of course, we treat some related or unrelated symptoms in the mouth. In particular, I'm responsible for oral care examination and treatment before and after radiation therapy, chemo, and surgical operations such as organ transplants, cardiovascular operation, and cancer surgery. Please take a look at this flow chart. This flow chart shows how patients with systemic diseases receive perioperative oral treatment. Medical doctor decided the hospitalization day for the surgery. And then the doctor introduced the patient to the hospitalization center. The hospitalization center nurse interviewed the patient on various things, for example, their oral conditions, such as a tooth movement, a toothaches, gingival swelling, and so on. And then the nurse make a reservation for our center. We perform oral treatment during the patient stay in the hospital. This graph shows the number of patients who have visited our center. As you can see, the number of patients had been increasing year by year up until the COVID-19 pandemic. The reason for the sudden increase in the number of patients since October 2016 is that I was just appointed as the director of the Peri-Operative Oral Care Support Center. Thank you very much. Just kidding. The reason for the increase in patient numbers is that medical doctors recognized somehow that oral care has a positive impact on the prognosis of surgery. Hence, we investigate the effects of preoperative oral care on patients who have received surgery. Using medical records, we performed a retrospective cohort study of patients who underwent major surgical procedures under general anesthesia at our hospital for 3 years. The number of patients is as shown here. I compared the number of post-operative hospitalization days, the number of days with elevated fever, and the percentage of patients with surgical site infections between the patient with and without preoperative oral care. I asked the statistician in my hospital to adjust for the difference in the patient's gender, age, surgical site, comorbidity, and surgical duration. We have statistically positive impacts, such as a reduction in the day of elevated fever and decrease in the percentage of patients with surgical site infections. However, significant differences could not be found in the number of hospitalization days. To determine the impact of preoperative oral care on patients who undergo the long-term hospitalization, further examination was limited to those who were hospitalized for more than 10 days. More than 10 days. In addition to the previous result, we found differences in the number of hospitalization days. The effect was a significant decrease in the medical costs of patients who received preoperative dental care compared with patients who didn't receive oral care. These results show that our center plays a very important role in Tohoku University Hospital. My contribution to the hospital was recognized. So I got the Hospital Director's Award. Thank you very much. I was so happy, but I seemed a little nervous. And why does the nurse behind me look bored? As you know, an oral bacteria called dentin caries, periodontitis, sinusitis, pneumonia, and post-operative complications. Focal infections caused by dental diseases in particular sometimes lead to serious problems for cardiovascular surgery or artificial joint replacement and so on. Before these surgeries, medical doctors ask me to treat dental diseases which may cause focal infections. Let me show you one case involving cardiovascular disease. This case is ventricular septum defect. The patient was a 20-year-old male. Before the cardiovascular surgery, the patient doctor recommended that he be checked for dental diseases. He visited his familiar dental clinic, and then the dentist told him that your oral condition was good and there were no problems with your mouth that would inhibit the surgery. After he stayed in the hospital, he visited our center in order to receive perioperative oral care. Please take a look at this panoramic radiograph. The left lower second premolar had a radiolucent region around the root and osteosclerosis with an indistinct border was found. I immediately told the medical doctor about this apical periodontitis. And then the doctor decided to postpone the surgery. I strongly argue that radiographic examination of the jaw bones is important for patients before cardiovascular surgery. In addition, oral bacteria might cause unforeseen systemic diseases. Case 2 is pustulosis palmoplantaris, abbreviated to PPP. PPP makes many small sterile cysts, mostly on the palms and soles. Attention please, take the skin symptoms shown here, pustular regions. The history. For the past 3 years, the patient had pustular region and itching in his bilateral palms and soles. Based on the diagnosis of PPP, he had been treated using steroid ointment. The dermatologist considered it to be a dental disease and referred him to our dental division. After the radiographic examination, we found a radiolucent region around a root apex on the left upper lateral incisor. As a dental treatment for this region, I performed an apicoectomy because this tooth had a long metal post that could not be removed. If I tried to remove this metal post, it would risk fracturing the root. 3 months after the apicoectomy, the pustular region disappeared like this. The patient told me that the itching stopped and the pustular region had dried up a few days after the apicoectomy. I considered that the PPP of this case had been induced by the focal infection caused by apical periodontitis. I proposed that an antigen-antibody reaction was involved in this case. Have you already learned about the antigen-antibody reaction? Antigen-antibody reaction is, of course, indispensable for keeping our healthy condition through normal immune reaction. However, this antigen-antibody reaction sometimes evoked overreaction, resulting in allergy or autoimmune disorder. Generally, we can produce antibodies against bacteria as an immune reaction, but occasionally, antibodies may cause the wrong immune reaction against our own uninfected normal cells or tissue by mistake. Here is an example of PPP similar to the one I just showed you. In this case, antibodies were produced by dental infections, maybe by alpha streptococcus. Then the antibody recognized the healthy epidermal keratinocytes as antigen by mistake. Consequently, an excessive immune reaction was caused by epidermal keratinocytes being misidentified, resulting in formation of pustular lesions in the palms and soles. Next, I will show you case 3, reactive arthritis. History. She suffered from arthritis for 3 months, but the case was unknown. She gave an important part of her history to the doctor of rheumatology, indicating that she felt spontaneous dull pain in the right lower molar for 3 months during the same period when arthritis symptoms occurred. Her doctor suggests that she visited our division. As for our first examination, she complained of general malaise and had a slight fever of approximately 37 degrees. Her joint extremities were swollen, which resulted in her inability to grasp strongly and walk. She visited our division using a wheelchair. This photograph showed the whole body bone scan scintigraphy. The intense scintigraphic uptake in the bilateral carpi and tarsals are found, indicating that bone destruction and regeneration had occurred in these areas. As shown in the clinical findings of her mouth, this tooth had a deep periodontal pocket, which was approximately 8 millimeters at the furcation area. From here, pus discharge could be seen. As shown in this intraoral radiograph of the right lower first molar, the root fracture of the medial root and the furcation involvement was detected. I extract the tooth because I judged that conservative treatment for the tooth was impossible. 3 days after the extraction, I got a phone call from her. She said that on the day of the tooth extraction, the symptoms in her joint had become worse. Then, the day after the tooth extraction, the pain in her joint had suddenly disappeared. When she visited our division 1 week after the tooth extraction, she proudly ran mincingly with her high heel shoes. We are very surprised and felt happy. Now she is playing tennis every week. There are many reports showing that reactive arthritis can be induced by focal infection from gastrointestinal diseases, urological diseases, etc. Our case suggests that the bacteria in the mouth can also be involved in reactive arthritis. As you can see, We hold an interprofessional meeting about new patients every day. They are oral surgeons, they are a preventive dentist, she's a dental hygienist, she's a nurse, and please have a look at this handsome man. I am facilitating the meeting. Every day, I state that there is an interactive relationship between systemic and oral diseases as both appear to be closely related. Now, let me show you some cases where I have strongly felt the importance of radiographic examinations which are taken by dental maxillofacial radiologists before medical treatment. Case 4 is small cell lung carcinoma. The patient was an 84-year-old male. His lung on the left side had small cell lung carcinoma with bone metastasis, and he had been injected with denosumab with bone metastasis, which is a bone resorption inhibitor for patients with osteoporosis. Many patients with bone metastasis use a bone resorption inhibitor because a bone destruction caused by bone metastasis sometimes leads to severe pain, bone fracture, and hypercalcemia. As you can know, checking the teeth and jawbone is important for patients who use drugs for osteoporosis because these drugs sometimes lead to medical-related osteonecrosis of the jaw. Please take a look at this panoramic radiograph. A horizontal alveolar bone resorption has been observed in many of the patient's teeth, and the cortical bone outlined in the right mandibular condyle is not clear. I'm sorry, unlike that of the left condyle. On CT bone images, erosive destruction of the cortical bone can be seen from the right mandibular condyle to the mandibular lamina. As shown in these post-contrast CT soft tissue images, a contrast-enhanced muscle region can be seen surrounding the mandibular lamina. These images are PET CT images. PET images reflect a glucose metabolism. Malignant tumors have a high glucose metabolism, resulting in malignant tumors that show FDG uptake. These images clearly show FDG uptake in the right mandibular lamina. Using these radiographic findings, we diagnose the case as being mandibular bone invasion by a metastatic tumor of lung carcinoma. In general, a patient with metastatic tumors that infiltrate the jaw bones have bad prognosis. In fact, the patient passed away 4 months after he had visited our center. Hence, detailed radiographic readings by our dental maxillofacial radiologists on the presence of metastatic tumors might be important when we examine patients who have cancer in various parts of the body. Next, I'd like to introduce a case where I found a genetic disease through a panoramic radiograph. Case 5 is duodenal cancer. The patient was a 42-year-old female. Before her surgery, he visited our center in order to check her mouth for any moving teeth that would inhibit intubation of the respiratory tract for general anesthesia and to receive perioperative oral care. I took the panoramic radiograph in order to check her periodontal condition. multiple osteosclerosis lesion could be seen. On her CT images, these high-density areas show multiple osteomas. Furthermore, as shown in her colonoscopy images, multiple colorectal polyps can be seen. She said that her mother had surgery at the age of about 40 years old for multiple colorectal polyps. Based on the fact that she had multiple osteomas in her jawbone and familiar multiple colorectal polyps, her disease was diagnosed as familial adenomatous polyposis, abbreviated to FAP. FAP is an autosomal dominant disease, and it is important to detect it early because these polyps tend to become malignant cancer at a young age. Furthermore, a patient with FAP have high carcinogenic risk in other organs. For example, the duodenum, the liver, and the thyroid. In fact, thyroid cancer was found a year and a half after she visited our center. Now, at regular intervals, she visits our hospital to take whole body examinations. Everyone, I recommend you that ask about the patient and his patient medical and his parents' medical history of colorectal polyps. If you find multiple osteomas in the jawbone on the panoramic or CT images, it may lead to the early detection of malignant cancer. Next, I'd like to introduce two cases of brain tumors whose symptoms appeared in the orofacial area. Case 6 is trigeminal schwannoma. The patient was a 43-year-old female. She complained about a loss of muscular sensation on the left side. History. For the past 2 years, she experienced a lancinating pain, pain on the left side of her face. This was investigated with MR imaging, which suggested the presence of a trigeminal schwannoma. 2 months ago, muscular disturbance and loss of muscular sensation on her left side occurred. MR image showed the brain tumor on the ganglion ganglion. As shown in this panoramic radiograph, there were no obvious disease in the left area of the mandible and maxilla. An electrical tooth test using TARP tester revealed no significant difference in sensory threshold between the right and the left teeth. She had lancet pain on the left side on her face. However, a facial sensory test using this tool revealed no significant difference in sensory threshold between the right and left side. The result showed that sensation still remained in her left side even though she felt the lancet pain. Why did she lose her muscular sensation? What do you think? I focused on the master muscle function because her master muscle function on her master muscle on her left side was thinner compared with her right side. Everyone, please put your hand on your cheeks and clenching your teeth. Can you feel the muscles swell up? The thickness of her master muscle measured through US showed an increase in the right side with maximum clenching and no increase in the left side. As you can see, the left side was thinner than the right in all cases. I suspected that motor deficit and atrophic change of the master muscle had occurred. In fact, the occlusal force while clenching was measured by the dental press scale system. It reveals only 6.3 newtons on the left side and was compared with 230.3 newtons on the right side. The motor evoked potential of the master muscle was recorded by means of electromyography. Results showed that it could hardly be observed on the left side, while normal amplitude was obtained on the right side. Treatment and progress. She underwent partial removal of the tumor, which was followed by gamma knife radiosurgery. 6 months after the treatment, her muscular sensation on the left remarkably recovered. However, her lancing pain still persisted. The thickness of the left master muscle had increased slightly while clenching. A motor evoked potential on the left master muscle could then be measured by clenching. The left occlusal force increased from 6.3 newtons to 108.6 newtons. In addition, her masticatory disturbance had completely disappeared. The motor deficit of master muscle in this case may be due to compression of the motor nerve by the Gastelian ganglion shear. I'd like to introduce another case involving a brain tumor whose symptoms appear in the orofacial area. Case 7 is pituitary adenoma. The patient was a 45-year-old female. History. A few years ago, her teeth in the right lower molar region had been extracted. Until now, she had never used a partial denture. As a result, a muscular disturbance on her right side occurred. She visited our hospital in order to make a partial denture. Her intraoral photographs showed that she had an open bite on the right side, unlike on the left side. However, please look carefully. Abrasion on her upper and lower canine were found, indicating that these canines were used to bite previously. Furthermore, enlargement of her nose and hypertrophy of the lower lip were apparent. She said that she could not put on her old ring due to the enlargement of her finger and that the size of her shoes increased year by year. Thus, she was still growing despite being 45 years old. The MR images show the tumor that can be seen in the pituitary gland. After all, the patient was given a diagnosis of acromegaly due to pituitary adenoma. Originally, a growth hormone is produced in the pituitary gland. So, tumors originating from the pituitary gland sometimes overproduce the growth hormone. I learned that the occlusal abnormality can be evoked by mandibular enlargement caused by overexpression of growth hormone produced by the tumor. I referred this patient to Dr. Hidetoshi Ikeda, who is one of the most famous neurosurgeons specialized in operating on the pituitary adenoma in the world. After that, he referred many acromegalic patients to me in order to examine link between the oral condition and acromegaly. He also suggests that I developed a new animal model of acromegaly. I decided that I would develop the rat model. let me explain the pathogenesis of acromegaly in more detail. Acromegaly is induced by the overexpression of the growth hormone in pituitary adenoma. When a growth hormone is secreted from the pituitary adenoma, insulin-like growth factor 1, IGF-1, is expressed in the liver. The hyperserum level of IGF-1 produces hypergrowth of bones and soft tissue of patients with acromegaly. Hence, I continue to administer human recombinant IGF-1 for 4 weeks using this tool on 6 10-week-old male rats. Control animals were injected with saline alone. After administration, all rats were housed for an additional 4 weeks. The serum level of IGF-1 was significantly higher in the IGF-1 group throughout the administration. After administration ended, serum IGF-1 level was similar in both groups. The change in body weight is shown in this graph. Our rat model appears to have an advantage because it allows us to access how changes occur both during the high serum level of IGF-1 and also after normalization of the circulating IGF-1 level. This rat model is also useful for the study on the changes that occur after operating of the pituitary adenoma. So, I plan to take a dental impression and lateral X-ray on the face in this rat model. It was difficult to do while the rat was alive. Then I considered this excellent device to prevent the rat from moving. I designed this device with the knowledge that rat cannot step backwards in mind. The device was supposed to force the rat to put its face forward so that I could take an impression and X-ray. However, the rat was able to bend his neck. Oh my goodness. As a result, I have only ever used this device once. Then I made this tool by myself from scratch. I used this cord stopper that is normally used on drawstring bags in order to fix the rat rims. And this tool is used to hold its mouth open. Everyone, do you know what this tool is? This is a custom-made rat dental impression tray. Everyone, do you think I could take dental impression using this tool? Bravo! So I was able to take a dental impression like this. This is my prized collection. Take a look. I made this tool to take lateral X-ray. These parts of the thread clipper fit perfectly into the rat ear. As you can see, the photographs are very clear. I also took an X-ray photograph of the femur as a reference. The mean value articulator is convenient for taking X-ray photographs of the femur. We compared the enlargement of the mandible with that of the maxilla and femur in our rat model in order to verify clinical findings which showed the enlargement of the mandible as the most severe skeletal change in acromegalic patients. According to our rat model, the mandibular enlargement is markedly greater than the maxilla and femur. As a result, it should be a useful contribution for studying the mandibular protrusion experienced by patients with acromegaly. In order to discern the effect on the dental arches, we investigated the change in the width and angle, and length and angle of the mandibular and maxillary dental arches. We found that mandibular arch growth was greater in the lateral direction than the anteroposterior direction. This result was consistent with the clinical report showing an increased lateral growth in the mandible of the humans with acromegaly. As a result, it is expected to induce a lateral crossbite in these patients. In clinical research on the cephalometric features in the maxillofacial morphology of patients with acromegaly, previous reports comparing acromegaly patients with healthy individuals have shown that excessive mandibular protrusion, increased facial height, and elongation of the mandibular lumps were featured characteristic of acromegaly. On the other hand, these features are also present in patients with non-acromegalic skeletal mandibular prognathism. However, skeletal differences in the maxillofacial region between patients with acromegaly and skeletal mandibular prognathism, such as skeletal class 3 patients, have not been investigated. Hence, we investigated cephalometric features found in the maxillofacial morphology of patients with acromegaly and class 3 patients. This figure shows the superimposition of mean facial prophylogram of patients with acromegaly and class 3 patients. The mandibular body length of acro was similar to that of class 3 patients. Interestingly, the tooth axis of the mandibular central incisor in acro was entirely different from that in class 3 patients. So I suggest that focusing on the angle of the mandibular incisor is the most practical way to differentiate acromegaly from class 3 malocclusion. Before the end of my presentation, I'd like to show you one interesting case in which the balance of bone formation collapsed. The last case is hyperparathyroidism, abbreviated to HPT. As you may know, a parasite hormone, abbreviated as PHT, plays an important role in the adjustment of the concentration of serum calcium levels. Hence, the hypercalcium level of PHT levels to the transfer of calcium from bone to blood, resulting in osteoporosis. The patient was a 42-year-old female. Old male. 6 months ago, he visited the urology division because of his ureteral calculus. He was diagnosed with HPT through a blood examination, which found abnormalities in his serum calcium and PHT levels. He visited our hospital's dental division in order to check his alveolar bone. The intraoral radiograph showed a high radiolucent of the alveolar bone and a loss of the lamina dura, which is one of the most common signs of HPT. CT images showed a parathyroid adenoma on the left side. As a result, he underwent a surgical treatment, parathyroidectomy. Actually, this patient was me. 10 years ago. Well, let's compare the picture from my first visit with my college days about 30 years ago. I was young at the time, just like you. I got old. In the radiograph from my college days, the lamina dura can be seen here. As you can see, the lamina dura disappeared because of my HPT. This picture is me at present. I got older and older. But as you can see, the lamina dura slightly recovered like this. Furthermore, calcium and pH serum level now show normal value. And let me say, I'm very energetic now, and I'm having a good time with many students from Indonesia. I'm looking forward to meeting you all someday. Thank you for your attention.
Okay. Thank you very much for your wonderful and insightful presentation. And also, thank you for posting my photo in your presentation.
Yeah.
So radiographic examination is very important, and followed with the dental treatment, proper dental treatment, it can play an important role in the management of patients with systemic disease, especially when the systemic disease is related and have a manifestation in oral and maxillofacial area.
That's right.
Okay, now we are moving to Q&A section. To all the participants who have a question, you can turn on your microphone or write your question in the chat box. So please, if you have any questions to Professor Ikubo. Okay, while we are waiting for question, can I ask you a question, Sensei?
Yeah, okay. Okay, but if you have any question, that's okay.
Okay. Speaking of systemic disease, I would like to ask your opinion about the osteoporosis. As you see I can see in your slide that you mentioned about the patient who treated with denosumab have a really low bone density in the jawbone, and yeah, osteoporosis is one of the research topic in our department a few years ago. And I also read that osteoporosis is also a problem in Japan. And there is many research that showed the use of panoramic radiograph for screening of the osteoporosis. So my question is, how do you think about the use of panoramic for screening of osteoporosis? Is it already implemented in Japan, or you have any other opinion?
Okay, thank you very much. Yeah. Many reports describe that the panoramic radiograph and the cortical bone formed is important to screening the osteoporosis. Yes, I think so. But I think the bone metastasis patient use the osteoporosis, the medication with osteoporosis. This patient don't osteoporosis. So I usually check the panoramic radiograph for the patient with bone metastatic patient. They don't have irregular outline in the panoramic radiograph.
I see.
Yeah.
Okay.
Yeah, very important to detect of the process because the QOL for the patient is important, not to fracture.
Yeah, I think so.
Thank you very much.
Thank you for your answer, Sensei. Is there any other question from the audience? There is a question in the chat box. I will read it for you, Sensei. So it's from Dr. Dina. So she is also staff in dental maxillofacial radiology from Airlangga University. So I will read it for you. Before asking, I would like to say many thanks to Professor Masahiro Ikubo for a very interesting presentation, adding new knowledge to me from what the professor has said. I can conclude that perioperative oral care is very important to pay attention to, consider and need to do, because it can reduce the risk of complications and improve the patient's recovery prognosis. Has it been implemented in health facilities or hospital in Japan and has become a standard protocol for performing perioperative oral care before performing surgery or other medical care? Because by looking at the benefits, I think it is important for every patient who is going to be operated on undergo this step and perform a dental radiographic examination. So she's asking whether the perioral health care is it standard protocol in Japan, and or is all the hospital or clinic in Japan has this kind of protocol before performing the surgery, Sensei? Please.
Yeah, and I want and I hope that I can do oral care for all patients, but Antenna, I cannot to all patients so far because at Tokyo University Hospital many patients.
Yeah.
So I can't do all patients, but I recommend do all patients. So I want and I ask. I have many staff for the perioperative oral care, but until now I have a few staff in our center.
Okay.
But I hope and want to do all patients. Yeah.
I see. So is this center only in Tohoku University Hospital or also any other hospital have this division, Sensei?
Yes, that's right. That's correct.
Okay.
So yeah, I have to spread out this system to
I see.
the world. Yeah.
Oh yeah. I think that is very great knowledge to us that there is this perioral health division that closely related to medical doctor, and yeah, we actually have a relationship with the medical doctor to treat the patients with systemic disease. So we still have a time to question. So if there is any other question from the audience.
Maybe can I ask a question, Dr. Ramadan?
Sure.
Hi.
Please.
Nice to see you, Ibu Sensei. Hi, you all. I am Saka. I'm also the students in Ikubo Sensei department. So nice to see you in the online meeting for my university conference, Sensei. Thank you for your interesting presentation. I really enjoy every case that you share because in Indonesia, we are as oral medicine specialists, we also do the oral treatment for the patient with systemic disease. Okay, and for what is your suggestion, Sensei, for us? Because sometimes we as a oral medicine specialist, we have some difficulties to do the pre-treatment before the surgery. Or if the patient have a systemic disease, it's difficult to screening the oral health before. The patient mostly is focused only on the systemic condition and only want to treat the systemic, not the oral health. So what is your suggestion, Sensei? Should we do the screening oral health before the surgery, or should we do the screening of the oral health if they have a systemic condition, Sensei? Maybe based on your experience as a dentist and also for the director of the perioperative dentistry, and also you also have experience, have the hyperparathyroidism. So maybe you can share your experience for us. Thank you.
Yeah, very, very important and difficult to correct answer because depend on the disease and depend on the personality. So sometimes the patient not accept the oral care. Sometimes, so depend on the patient character and personality and diseases and condition and the hospitalization days and the periods after hospitalization. So many patients I do the oral care. So I usually phone to the doctor. So and I usually receive the phone call from doctor. It is very important to have the strong collaboration. Okay.
Okay, Sensei.
Okay.
So
and,
we should
okay.
have a strong collaboration with the medical doctor who have a treatment the systemic disease to patients.
Yes. And if you have a question, Dr. Saka, this patient needs oral treatment. Please ask medical doctor and me. Okay.
Thank you, Sensei.
Okay. I think the time for the discussion session is up. And before I close this session, once again, we would like to appreciate Professor Ikubo for sharing your valuable knowledge to all of us. And we hope we can see you again in the future, and maybe in some occasion you can also visit Indonesia sometimes.
Okay.
Okay. And also thank you to all the participants for listening this session. Now I will return the session to Dr. Ratna. Thank you.
Thank you very much. Thank you, sir.
Thank you, Dr. Ramadan.
Yeah.
Now, may I request our Dean, Dr. Agung Sosiawan, to give certificate as an appreciation to our third speaker today, Professor Masahiro Ikubo, DDS PhD. Please, Dr. Agung.
Okay, thank you, Dr. Ratna, for the time. Professor Masahiro Ikubo, thank you for your very delightful lecture today. Is a certificate of appreciation for your willingness to be speaker in our Stovit online series. Hope we can have further collaboration in the near future, and nice to see you. Thank you once again.
Thank you very much. Yeah, thank you very much.
You're welcome.
Thank you. Thank you very much.
Thank you, Sensei, for your amazing lecture. Hope we can meet again in the future. And also, may I request Dr. Agung to give certificate to our moderator today, Dr. Ramadan. Please, Dr. Agung.
Okay. Dr. Ramadan, nice to see you again. After we long time cannot meet because your study in Tohoku or
Tohoku University.
Tohoku University. I hope you so healthy today and meet us again after you complete your study in Tohoku University. Here, the certificate. Nice to meet you again. Thank you, Dr. Ramada.
Thank you very much, Dr. Agung.
Yeah, you're welcome.
Thank you, Dr. Agung, for handing over the certificate of appreciation to our speakers and also moderator. Okay, ladies and gentlemen, in this fourth session, we have as Professor Dr. Aji Rafut Subhan Besach, DDS, MDSC, MA, PhD from Department of Oral Biomedical Sciences, Khon Kaen University, Thailand. He will talk about non-invasive and invasive technique for detection and diagnosis of OPMD, a clinico-pathological correlation. And in this session, we have Dr. Nurina Febrianti Ayuning Tias, Magister Kesehatan, PhD, Spesialis Ilmu Penyakit Mulut. I would like to introduce about our moderator today, Dr. Ayu. Hello, Dr. Ayu.
Hello, good afternoon, Dr.
Okay.
Ratna.
I will introduce a little bit about Dr. Ayu. She finished his Doctor of Dental Surgery in 2008 and Master of Dental Health Science in 2012. Dr. Ayu got her doctoral degree in dentistry in 2015 and also finished her oral medicine specialist study program in 2019. She has numerous articles published and her recent achievement is second best poster of research report category in 2020. Ladies and gentlemen, please welcome our moderator, Dr. Ayu.
Yeah, thank you very much, Dr. Ratna, for the kind introduction. And good afternoon, ladies and gentlemen, and also warm welcome to the respected colleagues, students, and also to our distinguished speakers. Thank you for joining us today in Stovit online series. So this event held in collaboration between Faculty of Dental Medicine Universitas Airlangga and also Faculty of Dentistry Hasanuddin University. My name is Nurina Febrianti Ayuning Tias, and I will be your moderator for the fourth session of today's Stovit online series. So this session topics, we will discuss about non-invasive and invasive techniques for detection and diagnosis of OPMD, oral potentially malignant disorder, clinical pathological correlation. These topics will be presented by Dr. Aji Rafut Subhan Besach. Just a brief information before we get started. If you have any questions during the event, please type them into the chat box in your Zoom control panel. And we will have the time for Q&A session at the end of the presentations. First of all, in this opportunity, let me introduce our distinguished speakers. For the IT section, could you please help me to show the video CV? So Dr. Aji Rafut Subhan Besach, he graduated from Khon Kaen University as Doctor of Dental Surgery in 1997. Then he continued to Faculty of Dentistry, University of Sydney, Australia, to pursue his Master of Dental Science in Oral Pathology and Oral Medicine and graduated in 2002. Last but not least, he took his doctoral degree and graduated as PhD in Dental Science from Hiroshima University, Japan in 2014. Currently, he works as Associate Dean for Education in Faculty of Dentistry, Khon Kaen University. Dr. Aji Rafut has numerous publications in top-tier journals regarding research, case report, and also epidemiological study. Now, we are going to the presentation session. Please welcome Dr. Aji Rafut Subhan Besach.
Good afternoon, everyone. Can you hear me clearly?
Yes.
So good afternoon, everyone. And first of all, I would like to thank Universitas Airlangga for giving me such an opportunity to share with you my knowledge and experience in the field of oral pathology and oral medicine, especially the oral potentially malignant disorders. First of all, I would like to thank Dr. Durina Fabrianti, UniTS, for inviting me to this symposium. And I hope that my talk will be beneficial to some of you, or if you have any questions, please don't hesitate to ask me, even to type on the chat, type your questions in the chat box. So first of all, I should share the screen first. Can everyone see my screen clearly?
Yes, Dr. Aji.
So the topic that I would like to talk about today is about non-invasive and invasive techniques for detection and diagnosis of oral potentially malignant disorders, clinical pathological correlation. So I just want to take just only half a minute to introduce you all to my university, Khon Kaen University, which is the first university in the northeast of Thailand. And my dental school is the first dental school in the northeast as well. So right now we are celebrating our 42nd anniversary, and hope that in the near future, when the pandemic is clear, I can invite you all to my dental school, which is quite very easy to access from Bangkok, only 40 minutes on the plane. So before starting my talk, I would like to clarify with you about the definition of precancerous lesion and precancerous condition. Actually, in 1978, WHO Collaborating Center for Oral Precancerous Lesions, they defined precancerous lesion and precancerous condition as a morphologically altered tissue in which oral cancer is more likely to occur than in its apparently normal counterpart. But in precancerous condition, they define it as a generalized state associated with a significantly increased risk of cancer. So that was many, many years ago. So back then, we had just only about 4 different diseases like leukoplakia, erythroplakia, palatal lesions in reverse smokers, as described as precancerous lesions, and submucous fibrosis, actinic keratosis, lichen planus, and discoid lupus erythematosus in precancerous conditions. The terms that we normally use in the international literature include precancer, precursor lesions, pre-malignant, intraepithelial neoplasia, potentially malignant, or epithelial precursor lesions. So all of them, later on, they changed it by a group of leading oral pathologists, as we know Dr. Simon Varnakun Surya very well, Dr. Johnson and Professor Van der Waal. All professors, they come together to define the potentially malignant disorders as a precancer. It's referred to precancer as it conveys that not all disorders described under this term may transform into cancer. So indicators of risk of likely future malignancies elsewhere in clinically normal appearing oral mucosa, and not only site-specific predictors. So they include several diseases in or lesions in the oral cavity, such as leukoplakia, erythroplakia, smokeless tobacco use, and smokeless tobacco keratosis, oral submucous fibrosis, and sideropenic dysphagia, or the so-called Plummer-Vinson or Patterson-Kelly disease, oral epithelial atrophy due to tertiary syphilis, chronic hyperplastic candidosis, lichen planus, especially erosive type, and proliferative verrucous leukoplakia. And then another group of oral pathologists, very renowned, both of them, Professor Carson and Professor Odell in England, they describe lesions with malignant change somewhat. They are just a little bit different from the previous definition. However, Professor Salman Ratkunsuria and Professor Johnson, Professor Van der Waal, finally came up with a group of potentially malignant disorders, including leukoplakia, erythroplakia, palatal lesions in river smokers. And then they also include some new diseases, such as some new lesions like actinic keratosis, and also hereditary disorders with increased risk of developing into cancer, such as dyskeratosis congenita and epidermolysis bullosa. So I will just give you a brief definition of each term before seeing some clinical pictures. I know that everyone, this term is very familiar to everybody in this room. Leukoplakia is a predominantly white lesion of the oral cavity of the oral mucosa that cannot be characterized as any other definitive lesions. Leukoplakia is a clinical diagnosis, so it doesn't convey the look of it in the histological point of view. The prevalence of leukoplakia is about 0.2 to 4% around the world. And with leukoplakia, the presence of leukoplakia doesn't correlate with the presence of epithelial dysplasia. So it may or may not be present in leukoplakia. And also it may show some atrophy and hypertrophy as well. Usually, leukoplakia can be divided into homogeneous and non-homogeneous, including speckled leukoplakia. So many working groups have been formed to define leukoplakia in the past decades. So the definition has changed from time to time, but last but not least, we use it as the definition in 1997, a predominantly white lesion of the oral mucosa that cannot be characterized as any other definable lesion. And then in 2005, so finally, they decided to call it as not defined. They tried to clarify the term not defined is like no distinction is made from other white patches. So Professor Wadakunsuria in 2007, he stated that leukoplakia should be used to recognize white plaques of questionable risk, having excluded other known diseases or disorders that carry no increased risk for cancer. So with the clinical types of leukoplakia, it's divided into homogeneous and non-homogeneous. So both of them, they are poorly clinical, and then they are based on surface color and morphological thickness or characteristics, and then they do not have some bearing on the outcome or prognosis. Let me show you the homogeneous form of leukoplakia. Usually it's flat and thin white lesion with low risk of malignant transformation. But if it's erythroleukoplakia or non-homogeneous leukoplakia, it has much higher risk of malignant transformation. So in the clinic, you will see the lesion as speckled, nodular, verrucous, or last but not least, is proliferative verrucous leukoplakia. So the term speckled means mixed lesion between white and red areas, but retaining predominantly white character. But then nodular, it means like the lesion itself contains some small polypoid outgrowth, rounded red or white excrescence. And then with verrucous, the surface is more wrinkled and corrugated. But the PVL, it presents with multiple or simultaneous leukoplakias in one oral cavity. So this is the white lesion, which cannot be scraped off and cannot be distinguished from any other lesion, which can appear white in the mouth. And also this is the white lesion in the floor of mouth area. So the surface is quite smooth. But then you can see some kind of, it actually starts to form some white and red area, mix it together. The red lesion, the red areas, it appears only in some small area like here or here. So the homogeneous or thick leukoplakia like this, especially in the sublingual area, we call it as sublingual keratosis, or so-called sand of ebbing tide. Because the appearance look quite like sand of ebbing tide after the ebbing tide occurs, and then it's not very smooth. So it's like the second level of developing into speckled leukoplakia. And then this is the granular leukoplakia, which means that the surface looks a little bit more lumpy bumpy, or sometimes you can see a very small dot, small papillated area on the surface, which looks like when you sprinkle some sugar grain on top of your toast. And then you can have the versiform leukoplakia, which does look like several small fingers. The differential diagnosis of leukoplakia includes so many types of white lesion from different etiology, like white sponge nevus, frictional keratosis, or morsicaccio ovacarum, also called chronic cheek biting, and any other types of white lesion which can occur in the oral cavity but with different causes, such as lichen planus, which is quite related to the autoimmune disorder, and also skin graft or hairy leukoplakia, which is related to HIV infection. This is leukoplakia. You can see that it's not quite flat, but then it's like the second level of leukoplakia, which can start to form some nodular superficial surface like this. And then you can see that sometimes you can be misled by the look of white lesion in the mouth, especially leukoedema, which you have to test by yourself by using the mouth mirror to retract the cheek, and then the lesion will disappear. And on the right hand side is white sponge nevus, which is the genetic disease occurring on the buccal mucosa mostly. So the family of history of having the same lesion is very important to make a differential diagnosis. This is also another white lesion which can occur in the mouth, especially in a patient with chronic renal failure. You will get to have the uremic stomatitis, which is the white lesion occur in the oral cavity, not only on one side, but overall in the oral cavity because of the retention of urea in the blood. And then this is very easy to recognize. It's frictional keratosis. So it occurs on the area where you have the prosthesis or the area where the opposing tooth occlude on top of it. So malignant transformation of leukoplakia is about 0.3 to 1%, but it's much higher for non-homogeneous types, and it can develop within the site of pre-existing leukoplakia or elsewhere. Risk factor of leukoplakia consists of female gender, and then with the long duration of leukoplakia, and then sometimes the leukoplakia in non-smoker is very important that you have to check the history, because if the leukoplakia in non-smoker tends to develop into oral cancer more easily than the leukoplakia in the smoker. And then the location on the tongue and floor of mouth, both areas are very prone to develop into cancer. Size should be more than 200 millimeters square, and then usually it's non-homogeneous type, and if you can see some candida albicans, so it can aggravate the lesion, and then it can uh, accelerate the rate of malignant transformation. And the presence of epithelial dysplasia is the most important indicator of malignant potential. So it depends on how you eliminate the cause. If you can eliminate the cause very well and you have good response, so the management is right. But if there's no response after you eliminate the cause, you need to do the biopsy. After that, you have to decide whether you want to treat it as the dysplastic leukoplakia and also the non-dysplastic leukoplakia. It depends. And management of leukoplakia, actually the reasons to treat are a presence of symptom and also just to prevent the malignant transformation. So usually management of leukoplakia, it varies from place to place. So you can have surgical excision, cryosurgery, laser therapy, or even retinoid application. But with potentially malignant disorder, you probably wait and see, and then you ask the patient to stop smoking. After that, you start the surgical treatment like use the blade biopsy and also the cryosurgery, laser therapy. And also the same thing that has been used in many literature is vitamin A, retinoid, beta carotene, and carotenoid. Erythroplakia, on the other hand, is a fiery red patch that cannot be characterized clinically or pathologically as any other definable disease. So the etiologic factor includes tobacco, alcohol, and Candida albicans. So usually erythroplakia is rather it usually has a granulated surface rather than smooth surface, and it can occur in middle age and elderly. Usually it's solitary and it has a very high risk of malignant transformation. As you can see this lesion is not very flat. It has very granulated surface. Also on the left lateral tongue, you can see that the lesion has a very rough surface. And you can tell that this red lesion looks very worrisome. So normally we need to do the biopsy to confirm diagnosis. This is the speckled leukoplakia, as I mentioned before, that it's include both areas, white and red areas in the same lesion. So histopathology of the erythroplakia and leukoplakia, usually it can be defined as dysplasia, carcinoma in situ, or even invasive carcinoma. This one is the dysplasia. It's called the severe dysplasia. That means like the change of the malignant change occur in the full thickness of the epithelium. And the differential diagnosis of erythroplakia includes some immune disorders like pemphigus pemphigoid or lichen planus, infections like erythematous candidosis or histoplasmosis, and then hematomas like hemangioma and Kaposi sarcoma, as you can see in HIV positive or HIV/AIDS patients. The next one is smokeless tobacco use and smokeless tobacco keratosis. So spit tobacco use is very popular in India and Southeast Asia. Usually they start chewing tobacco and also betel quid early in life, about 8 to 14 years of age. So it depends on the habit and also the brand and also the onset of tobacco use. And last but not least is about the total hours of daily use and amount of tobacco that they use each time. This is tobacco or smokeless tobacco. In Thailand, we have the tobacco wrapped by dry banana leaf. It's used in the northern part of Thailand called buri kiyo. So I remember that last time when I visited Alanka University, I was taken to the tobacco museum, and I was really impressed with the gradak type of cigarette as well, because it smells so good and it sounds very interesting. And then in Thailand now, because we have so many foreigners coming to to make a to live in Thailand after retirement, on the right hand side, the corner, you can see the um, this one it's called sorry this one is called snus. It's like the smokeless tobacco put in a bag made by a membrane. So when you put inside the mouth, it will be slowly uh, released from the area where you put this sack in. So it's very popular in Scandinavian. So people from Scandinavia, they use this type of smokeless tobacco quite a lot. Betel quid chewing is very popular in the northern part of Thailand and also in the rural areas of in the northeast of Thailand as well. So they use betel nuts and also the tobacco uh, leaf, shredded tobacco leaf to actually to absorb the saliva and also to rub against the some leftover uh, the beetle on the teeth. And then this is the type of betel quid that they use in the southern Asia, like in India and also in many countries. So usually when they put the smokeless tobacco and also after they chew the betel nut or betel quid, so if they put the smokeless tobacco in, the area exposed to that smokeless tobacco will change into white color. So it's called snuff dipper leukoplakia or tobacco pouch keratosis. And then when you do the biopsy, you will see that the epithelium exhibiting acanthosis, which means the increased thickness of the stratum spinosum, the overall thickness of the epithelium, and also the increased thickness of the keratin on the surface layer, as you can see here. And then in tobacco pouch keratosis, it can have mild hyperkeratosis and acanthosis, and also linear deposition of eosinophilic material just above the minor salivary gland of the labial mucosa. They're quite closely related with the smokeless tobacco use is oral submucous fibrosis or OSF. So it's a chronic progressive scarring, high risk precancerous lesion. Usually it's very popular in Indian and subcontinent and Southeast Asia. And it's linked to the chronic placement in the mouth of a betel quid or pan. Because alkaloid from the betel nut can be released by slake lime, and then it can make the user feel euphoria. So usually after chewing betel nut, betel quid for many years, you will get scar, and especially in the posterior part of the oral cavity and also the soft palate. Not only that, you can also get the scar on the labial mucosa as well. So the clinical features, the patient cannot open the mouth very wide, and then it can lead to some xerostomia and melanosis and burning sensation. After that, the marble-like pallor and also a progressive stiffness of subepithelial tissues will occur. It depends on the area where you put the smokeless tobacco in as well. I mean the malignant transformation. But submucous fibrous band usually can be found on the bilateral buccal mucosa, soft palate, and labial mucosa. So in the histopathology, you can see that it has fibrosis in the lamina propria, which means the the area here, it has more collagen deposition. And late presentation of oral submucous fibrosis, it will lead to limitation of mouth opening and also woody changes to mucosa and tongue. And this one is like the reverse smoker, the tobacco keratosis in reverse smokers or heavy smokers. You can see some red dots here, as the red dot here represents the inflammation of the opening of the minor salivary duct. And also the new classification, they include actinic keratosis or solar keratosis, which can occur in the sun exposed area. You can see that there are some dysplastic change in the overlying epithelium, including the hyperchromatism of the nucleus and also the basal cell hyperplasia, the increase of the number of basal cells. So actinic chelosis can occur in the lower lip mostly because it's exposed directly to sunlight. And at the same time, squamous cell carcinoma can arise in the area of actinic chelosis, which you can see solar elastosis. The elastic fiber has been destroyed by the sunlight, especially here. This is solar elastosis, which means the elastic fiber has been destroyed or denatured by the sunlight. Patterson-Kelly or siderophonic dysphagia, it has high risk for SCC of the esophagus and posterior of the mouth. It actually is caused by iron deficiency anemia, very severe iron deficiency anemia, and it can cause esophageal webs as well. And patients often show angular cheilitis and also foul tongue. This oral epithelial atrophy due to tertiary syphilis is very rare, and only the tertiary syphilis is associated with dorsal tongue carcinoma. But these days, we can see more and more secondary syphilis, especially if the patient don't have the protective sex. And this one is chronic hyperplastic candidosis, because certain strain of candida can produce nitrosobenzyl methylamine. So nitrosobenzyl methylamine is also a carcinogen. So that's the main reason why we need to get rid of the co-infection of Candida albicans, just to reduce the risk of developing into the carcinoma in the lesion of chronic hyperplastic candidosis. Proliferative verrucous leukoplakia is a subset of idiopathic leukoplakia. It's associated with HPV 16 and 18, and it can occur in low risk group of patients. So normally the patient doesn't smoke, doesn't drink, but if it occurs like many lesions at the same time in one oral cavity, the transformation to verrucous carcinoma and SCC will be occur very easily. So Hansen, Olsen, and Silverman, they describe the development of the leukoplakia from normal until it develops into verrucous hyperplasia, verrucous carcinoma, and papillary squamous cell carcinoma. So usually white keratotic patch is associated with adjunct erythematous mucosa, and after that it will spread, and then it will accompanied by erythematous changes. And after that, the superficial surface will be very severely erosive. After that, the clinical picture will not be distinguishable from verrucous carcinoma. So if you see many white lesions, very ragged surface in the oral cavity in a low risk group, you have to think of this lesion, PBL. And then oral lichen planus, as you can see this picture, it has very beautiful pattern. We can call it as reticular pattern. So if they show only reticular pattern on the bilateral buccal mucosa and desquamative gingivitis, the risk of developing into cancer is not very high. But then in erosive type, it can be potentially malignant, and it needs to be closely observed, especially in recalcitrant cases when you only try to treat the lesion with corticosteroid, but it doesn't heal. So usually with pathology of lichen planus, you have the lymphocytic band of lymphocytes, and then when you use the steroid, you will make this band disappear. And because the accumulation of the lymphocytes will induce the breakage of the basal cell, especially in the form of liquefactive degeneration. And then lichenoid reaction, it's now also reported as it's related to the potentially malignant disorder, and also graft versus host disease when you have this lesion after the organ transplant. Discoid lupus erythematosus, it's been in the classification for a long time and still there. We have to consider if we cannot treat, if the condition of the patient with SLE or DLE is better, but the lesion doesn't disappear, you might need to do the biopsy. And this is epidermolysis bullosa and this keratosis congenita, the two genetic diseases which have been reported as closely related to malignant transformation. So WHO criteria, it includes the pathological changes and cytological changes in the epithelium. So I have to show you just a quick look of my dysplasia. The changes will be limited only in the basal part of the epithelium. So basal 1/3 of the epithelium will change. And then moderate dysplasia, it's about half of the thickness. The pathological, the histopathological features will show some nuclear and cellular abnormalities. And then you have severe dysplasia and carcinoma in situ. And later on, you might develop microinvasive carcinoma. So with this grading of dysplasia, it actually starts from hyperkeratosis, which means the outer part of the epithelium increase in thickness. Mild dysplasia, moderate, and carcinoma in situ will develop later. So I will show you the screening test that we use for diagnosis of oral cancer and precancer. We have standard screening tests and established diagnostic adjunct and also light-based detection systems. So I have only limited time. I show you the conventional oral examination that you normally do as a screening test. We usually use the protocol of National Institutes of Health from the US, because they found new cases of oral and pharyngeal cancers almost every year, and it caused a lot of death. And then 5-year survival rate for localized disease is about 76%, but if it metastasizes to distant organ, the 5-year survival rate is very low, to less than 20%. So the overview, you have to take a history of alcohol and tobacco use because it's closely related to cancer. And then you use the proper lighting, dental mouth mirror, gauze, and gloves for 5 minutes, starting from extraoral examination from the lip. And then you have to look carefully on the labial mucosa, both upper and lower mucosa, and buccal mucosa, both sides, left and right. And then you see the gingiva, the tongue, and then the lateral side of the tongue. After that, you ask the patient to lift the tongue up to see the floor of mouth and the ventral surface of tongue, the floor of mouth, and then the palate. After that, you use the tongue blade to ask the patient to pronounce like "ah," like that. And last but not least, you use by digital palpation or by manual palpation to palpate the gland. So brush cytology is the first diagnostic tool that I would like to introduce to you. So the CDX laboratory in New York, they introduced this technology since 1999. So usually they report the result as positive, atypical, or negative. But then this type of cytology test is very it does cost a lot of money, and it's not very convenient to several countries. So the oral CDX, you use the type of brush to remove the top part of the epithelium, and then you spread it onto the slide. So actually they adapted the brush from the cytological brush that they use in the cervical cancer smear. And then you can see that on the top right picture, you have to make the area bleed to make sure that you get the whole thickness of tissue. After that, you send it to the, sorry. Excuse me. Sorry for the interruption. Okay, so the oral scan will do the job by analyzing the surface epithelium that we remove from the surface from the area where you do the biopsy. The second type of analysis is called image-based DNA ploidy analysis, which is quite predictive and also very complicated. But then it can use the fundamental of DNA ploidy analysis to be a more accurate predictor of malignant transformation. But also the same problem, because this image-based DNA ploidy analysis used a very expensive machine, and it has a very complicated procedure. So it's available in some leading institutions in the world, like in England or in America, that they use this type of machine to analyze. But because the number of cases suitable to use this analysis, and also the convenience when you use it, both reasons are very important to us. So it's not very popular in especially in Thailand, in our country, but it can give a very promising result. And then my colleague, Dr. Glandrit, Dr. Palamapon Glandrit, she used this technique to detect the changes in the verrucous carcinoma, and then she claimed from the previous published paper that this technique is very reliable in terms of detection of the malignant change in the cellular level. Like this one, you can see some dysplastic change, but then this is very highly malignant. Toluidine blue staining, also known as toluenium chloride, it's a vital dye that may stain nucleic acid and abnormal tissues. It has been used as the adjunct tool for detection of cancer for decades. But it's positive in only about 50% of lesions with dysplasia. So it helps assess the clinically suspicious lesions and help map sites for incisional biopsy. So the dysplastic tissue will appear as blue color. Usually you apply the 1% toluene blue on top, and then you ask the patient to rinse the mouth, and then you wipe it again with 1% acetic acid. The remaining color is the area suspected for cancer. So you need to take the biopsy from this area, the blue stain area. And then the sensitivity is about 95%, but specificity is about 71.4%. So you need to be careful about this technique. But however, it can be a very useful diagnostic, adjunct diagnostic tool for detection of cancer. In Thailand, we also use glucose iodine, which is a solution of elemental iodine and potassium iodine. So this plastic tissue will appear as pale. When you apply the glucose iodine, the sensitivity is about 94.7%. The specificity is about 83.8%. But unfortunately, if the lesion is not white, it's really hard to detect from glucose iodine. So usually we use it in the leukoplakia mostly. A group of oral medicine specialists in Thailand, they also use vinegar. Actually, you can tell that the vinegar or acetic acid has been used with the toluidine blue, right? So this one, they use solely acetic acid to detect the oral squamous cell carcinoma. They claim that the sensitivity is about 87.93%, and specificity is quite high, it's 86.36%. But it's really hard to use in the leukoplakia because you cannot tell the difference between the area of leukoplakia and the area of cancer. So this lesion is actually good for very clear squamous cell carcinoma, and you want to see the extension of the lesion in the area. The light-based detection systems, we have VisiLight and WellScope. We're running out of time. So usually VisiLight and WellScope, you have to ask the patient to rinse the mouth with 1% acetic acid, and after that you use the direct visual examination by using blue and white light source. So VisiLight, it comes with disposable light packet, but then other companies, they use the reusable battery powered light source. Sorry, that's the VisiLight itself. They use the battery powered light source, and it can provide some the use with toluenium chloride or toluidine blue. So the sensitivity is quite high, but the specificity it's not very reliable. So they have the VisiLight luminoscopy. So normal epithelium will absorb VisiLight, and then the abnormal will appear white, which is very important. It is very difficult to detect. So they give you the oral lesion marking system by using the toluidine blue as well. And then this is where what they show the results on the Visilite exam. So you can see that the moderate dysplasia and epithelial hyperplasia will not show anything. But then with carcinoma in situ, the area where the malignant changes occur will appear white with the blue light. This is the microlux with acetic acid 1%. And then the more useful and more widely popular is Wellscope. They use the intense blue excitation light about 400 to 460 nanometers in normal oral mucosa and also the suspicious oral mucosa. If it's normal, it appears green, but in the area where suspicious malignant transformation occur, it will appears as black. So the area where you will do the biopsy is the black area, where the light cannot re-emit to the surface like this. So last but not least is about biopsy. So I would say that this is the very old technique. It's a conventional technique to obtain a very representative area of malignant change. So you have excisional and incisional biopsy. The excisional biopsy, you remove the whole lesion. Usually the diameter should not be exceeding 1 centimeter. And if the lesion is widespread, you have to do more than one biopsy. And punch biopsy, it can be used in the amateur. So someone who doesn't like to use the blade that much, you can try with punch biopsy. With fine needle aspiration, you can use it in several far-fetched area or some it's very difficult to approach, like in the swollen gland or swollen lymph node. But in the oral cavity, if we can do the conventional biopsy, we don't tend to use the fine needle aspiration that much. So I have to skip this because I think time is up, right? So I show you quickly with the case that I prepare. Like this one is before the incisional biopsy. She's an old woman, 82-year-old female. She was referred to our institution of 2-year history of untrappable shaggy white plaque with some erythematous area on the lower lip. And then because the surgeon sent this patient to us because she had oral squamous cell carcinoma on the right buccal mucosa before. She also had Parkinson's disease, DM, and hypertension, and also she was a persistent user of betel quid for 40 years. So this is the area, and then we take the biopsy. You can see that the thickening of the stratum corneum, the orthokeratosis is very thick, is even 3 or 4 times thicker than the actual epithelial thickness. And then it doesn't show any dysplastic change. So the second case, she's a 61-year-old female with burning sensation and soreness of the area of white plaque. It persists after topical steroid use. She had well-controlled DM with no lymphadenopathy. This is before the incisional biopsy, and this is after the first incisional biopsy. We found that the epithelial dysplasia, moderate epithelial dysplasia, occur in this case. So we need to ask the patient to have the whole lesion removed because it has a potential to develop into cancer. Case number 3 is a 73-year-old female with well-controlled DM. She chewed betel nut for about 30 years, but she already quit it 15 years ago. But she actually had palpable right submandibular lymph node. This is the area. And the left-hand side, you can see the fibrous band of submucous fibrosis. The white band is submucous fibrosis. The right side is a irregular surface of ulcers. So after we took the biopsy and removed the cause, usually you can see that we extracted the tooth because the tooth, the 4-6 was very wobbly. So we removed the cause, but the lesion still persists. And then you could see that on the left side is the normal oral mucosa. On the right side is the malignant change. You can see that usually this plastic change doesn't occur gradually. You can have like very sharp transformation from normal oral mucosa to malignant change in this case. So I just want to finish my talk with lesions mimicking oral cancers, just to make sure that you won't miss these lesions with you won't mix it up with the oral potentially malignant disorder. First of all, is oral tuberculosis. Normally, if the patient is a known case of oral tuberculosis, they might have some cancerous, I think like cancer looking lesion in the mouth, especially on the lateral side of tongue or on the palate. But then after the biopsy, you can see lots of germs, the Mycobacterium tuberculosis and granulomatous inflammation. They form the Langhans giant cells and then the caseous necrosis in the center. Next is deep fungal infection, especially in poorly controlled diabetes. The diabetic patient, you have the mucormycosis, which is very prevalent, especially in the northeast part of Thailand, in the poorly controlled DM. So you get a very necrotic area in the oral cavity, and also some red lesion on the gum. It represents the histoplasmosis. This patient is also HIV positive. Traumatic ulcerative granuloma with stromal eosinophilia or TAXI is something that you need to be concerned about. When you look at it, it looks like cancer. That's why you need a biopsy to confirm whether it has the malignant change in the area or not. Usually this lesion, it can be disappeared. It can disappear after you remove a piece of tissue from the area to induce the blood supply. So traumatic ulcerative granuloma with stromal eosinophilia is these days is very frequently seen, and the surgeon always sent to the oral medicine specialist to the oral medicine clinic to consult whether it's a pre-malignant lesion or not. Necrotizing cellometaplasia is the ischemia of the palatal tissue after injection. So usually when you have this kind of lesion, the palatal mucosa will appear as the persistent ulcer. But then if you do the biopsy, the area will disappear, as you can see in the traumatic ulcerative granuloma with stromal eosinophilia. Actually, in the histopathology, it does look like cancer because it's a proliferation of the duct of the minor salivary gland after the minor salivary gland has been atrophic by the local anesthetic. Okay, so that's all for my presentation. So usually with the oral PMD, it's very important in Southeast Asia because we still have very high prevalence of oral PMD and also the oral cancer. So if anyone has any question to ask, I am willing to share my thoughts. Thank you very much for your attention, and sorry for my late presentation because I tried to cut out about 100 slides and and then now I finish it lastly. So I'm very, very relieved.
Thank you. Thank you very much, Dr. Ajirafut. It's very impressive and also clear presentation.
Thank you.
Before we go to the Q&A session, I would like to, a favor to your students, to Dr. Tricia and Dr. Kurt, also Dr. Pema, to turn their camera on because we need to do the screenshot in the gallery view. So thank you very much. It looks like that we have a few questions in the chat box. So I will read for you, Dr. Aji. First came from Dr. Pema. Dr. Pema asked two questions. First, asked about leukoplakia. If leukoplakia presents with mild epithelial dysplasia, does it mean less chances of malignant transition rate? And does it mean we can keep the lesion under observation with habituation only? And the second one, it's about lichen planus. So is it only erosive lichen planus that indicate potential malignant transformation? In your experience, does long-standing and non-healing, non-erosive oral lichen planus indicate suspicion of malignant transformation? So maybe you can discuss about the first two questions from
Okay.
Dr. Aji.
Okay, thank you very much, Dr. Tima, and thank you for your questions. Very important and very interesting questions. So, with my epithelial dysplasia, and if it appears as white lesion, so usually after we do the biopsy and the result come back with the my epithelial dysplasia, usually we observe for maybe 3 months, and then we have to have a close observation about the changes on the surface. If the white lesion does not change, so we might actually, if it's small, sorry, if the white lesion is very small, in our institution, we usually ask the patient whether they want the lesion to be removed or not. If they want the lesion to be removed, it's safer. I mean, to prevent the what is it called, to get rid of the chance of developing into oral cancer or more severe epithelial dysplasia. But then if the patient doesn't want to have it removed, because normally they ask whether it's cancer or not, we cannot say this is cancer. We just say that it's a kind of dysplasia or some kind of epithelial change, so which can lead to cancer someday in the future. So we need to leave the decision to the patients whether they want the lesion to be removed or not. In my experience, I feel that we need to have a close observation, but usually patients will be very cautious about this lesion. So they will come and ask us to remove the lesion for them anyway in the very near future. So you have to give all the information that you get from the oral pathologist, and then you discuss with the patient whether the patient would like to have it removed or not. So I think that's the best way to communicate with the patient and also to decide whether what you would like to do next, because you cannot tell whether the area that you take the biopsy is the most representative area or not. If you're not sure and you think that it might have some chance of developing into cancer, you can ask patient whether can I do another biopsy if the lesion is very big like that. So that's for the first question. The second question is about the erosive lichen planus. In my experience, many cases of erosive lichen planus, last but not least, they will have dysplastic changes, like from moderate to severe dysplasia. So recalcitrant cases, I think in erosive lichen planus, it should be removed because it's very risky to leave it like that. And then because in many countries, especially in Thailand, the patient come to the clinic very difficult because they need to spend a lot of money traveling. So if we can do it in one go, like try to solve the problems in if we can control it. I think that's the best way. But then you asked the second question about long-standing and non-healing, non-erosive oral lichen planus. Usually, if you feel like this lesion has been there for too long, you can ask the patient to decide whether they would like to have a biopsy or not. Because last but not least, I just feel that the biopsy is very important, especially in many countries where we don't have like very high technology. I mean, like to detect the malignant change, like I mentioned before, because they are very costly, and also sometimes it's not very practical in the clinic. So I think that's all for my answer. I think it
Yeah.
depends that you have to
Yeah,
ask the
thank you so
patient.
much. Yeah. So actually, we should ask the patient also, right, Dr. Aji?
Yep.
Whether it's also the patient option that maybe the patient wants to be taken. I mean, taken the lesion or not.
Yep.
That if not, we can do the routine follow up for
Yes.
after about 3 months. Or
Yes.
is it
Yes.
is there any difference between the how to say the white lesion or maybe the red lesion? So for the time interval for taking the follow up, is there any difference?
So to me, the white lesion, if it's flat, it doesn't have rough surface or corrugated surface. I think you can wait and see after you remove all the causes, and then probably 3 months would be a very good period of time to wait and see whether you would like to further treat this lesion or not. But then with red lesion, I think if you cannot remove if you can remove the cause, but the lesion doesn't disappear or doesn't get better, I think that's worrisome. Normally, with red lesion, it's more worrisome. I would say that the biopsy should be done immediately. If you remove all the causes, probably less than 2 weeks, you should do something about it if it doesn't change.
Okay, thank you very much. It's clear. And I think it's also has answered the question from Dr. Kurt. So we move to another question from Dr. Lani. So she asked about discoid lupus erythematosus about the biopsy. For that disease, is a biopsy is needed or not? And also, do all cases of discoid lupus erythematosus always require a biopsy? Or are there certain conditions that indicate that the case is already leads to malignancy? So we need to do a biopsy.
Oh, thank you very much for this question. I think discoid lupus erythematosus, actually, when you look into the mouth, and it does, sometimes you can, I mean, like you cannot very easily differentiate it from lichen planus sometimes. And also, like, reaction these days when the patient use so many types of medications, and it can result in the same clinical presentation. I would say that with discoid lupus erythematosus, the lesion should be biopsied, because if you biopsy that, sometimes you will discover that the patient, if she's not a known case of SLE or DLE, the histopathology, it has some difference from oral lichen planus when you look into under the microscope. So it might help you to distinguish the underlying disease if she's not a known case of LE. But then with the reports of malignant transformation of this discoid lupus erythematosus, it's been reported uh, for uh, for many years. And then because the lesion in the mouth, it might look uh, quite ulcerative and also somewhat keratotic. So I think it's sort of like we can put it in the category of spectral leukoplakia sort of thing. So when you do I would recommend you do the biopsy, no matter you are very sure that this is the discoid lupus erythematosus or not, because sometimes, as I answered the previous question about the erosive lichen planus or even recalcitrant lichen, non-erosive lichen planus, I think biopsy is needed to confirm the malignant change in the local lesion in the mouth of lupus erythematosus. So I think that's all for the question.
Thank you very much. I see. So we can continue to the next one. The next question came from Dr. Aulia, and she asked about the. At first, she said sorry because she thinks that this is very basic questions. Now she is our resident in our department. She asked about the etiology. Actually, the etiology of OPMD, like erythroplakia, leukoplakia, is quite similar, right? From smoking and also bitter nut chewing. So she wonder why, yeah. She wonder
I know.
why we can see two different manifestation in oral cavity, like one in red
And
color,
white.
and the other one
Yep.
is white
Yep.
color.
It's very, very hard to answer question, I would say, because this this question has been proved, and has not yet been successfully proven that like why it becomes red and why it becomes white when the etiologic factors are the same. So I would say that because I didn't prepare the what is it called, the PowerPoint for this answer. It's a very big question. You need to go back to there's a hallmarks of oral cancer. Hallmarks of cancer. There's so many types of etiologic factors which can lead to cancer in every organ, including the oral cavity. So each person, like we are human beings, but we are not similar in almost every detail. Like we are different in some ways. So some people can have like the potential of creating some white plaque more than other patients, or some patients will have like the chromosome abnormality deep down in their blood, sort of. So the response of each differences will lead to the different clinical pictures, and also the clinical features that you see, whether this patient he's a heavy smoker, why he doesn't develop any kind of cancer, why the other person who is also heavy smoker might have a frank carcinoma. It's really hard to tell. It's like tailor-made. Each person will have the same risk factors, but they will respond to that risk factor differently in a very, very different way. So I think that's what I can answer by now, because otherwise, if we know everything about malignant transformation, we wouldn't have this seminar. Like everyone knows everything, so we don't have to discuss about it. But it's very, very, very difficult to answer, and it needs some discovery in the near future. I still hope that in the near future we will have a very good system to detect the malignant change or dysplastic change, so we can help the patient in time before it develops into cancer.
Sure. Thank you, Dr. Ajirafut.
You.
So actually, I agree with your answer, because the response from the oral mucosa should be different for every individual, for each individual. So actually, I want to ask one more favor to your students, because I think Dr. Kurt and also Dr. Tricia not yet turn on their camera. So could you please turn on the camera, Dr. Kurt and also Dr. Tricia? Thank you very much. And we still have around 4 minutes left. So maybe we can continue to the next one from Dr. Ari. So Dr. Ari asked about the salivary biomarker. Is there is there any opportunity we can use salivary biomarker to detect OPMD cases, Dr. Aji?
Right now, as I know, they are trying to develop some kind of salivary biomarkers. For OPMD, I'm not sure about that because I think it's really hard to detect. But for salivary biomarkers for the frank carcinoma, I think they're developing it, and I think we're going to have it very soon. I mean, like the biomarker for cancer, for PO cancer. But for OPMD, because as I told you before, that we have so many um, risk factors, so many factors can lead to these plastic changes. So with the OPMD, I still think that we need a long way to go to have these salivary biomarkers. But for oral cancer, I mean, like the frank carcinoma, I think it's easier to detect. I mean, it depends on what should I say, the the factors related to malignant transformation, also the chemical agents that we use in the mouth, like the toxic agent in the cigarettes, and also from the betel nuts, like that. But then I do hope that salivary biomarkers to detect OPMD will be available in the future. I wouldn't say in the near future. These days they try to develop just only salivary biomarkers to detect if like cancer in in the mouth, like when you look into the mouth and it does look like cancer, but you don't want to do like you want
invasive,
you just want to do it right now, just
Yeah.
spit it and then just check whether this lesion may be cancer or not, and then they can prove it to you. But then with OPMD, it depends on types of factors related to the lesion as well. So yeah, in the future, I think we're going to have that.
Yeah, thank you very much. I think I saw Dr. Andra raise hand. Dr. Andra is
Andra?
maybe you know Dr. Andra. He's now our vice dean.
Ah, hello,
so please,
Andra.
Dr. Andra.
Hello.
Hello,
Aji-san,
Andra.
how are you? It's really nice to see you again.
Yeah, it's nice to see you too, Andra. How are you?
How are you? Fine, thank you. Dr. Aji, I want to ask you something.
Okay.
So in your presentation, you mentioned about malignancy, right?
Mm-hmm.
No, I will not ask you about malignancy, but I will ask you about ameloblastoma, as we discussed before.
Okay.
Before, and I think ameloblastoma is your topic when you took the PhD program. I want to know what is your opinion about ameloblastoma. So I mean that after operation, we seldom to get the two type of diagnosis of ameloblastoma. So for example, in one tumor of ameloblastoma, there is sometimes there is a follicular and plexiform. What do you think about that, Dr. Aji?
Okay, I would say that ameloblastoma is a very intriguing tumor. So actually, these days, as an orthologist, I wouldn't write down the subtypes clearly in my report. I usually put ameloblastoma and then I describe the histological features that I see from that case, because you know what? These days, lately, I got a case referred from the nearby province with a huge ameloblastoma on the left side of the mandible. But then the first biopsy that the surgeon did, it was desmoplastic ameloblastoma. So I reported it as desmoplastic type, but after that, he removed the whole tumor. And then because for the protocol in our lab, we need to select like several representative areas of the whole tumor. So the anterior part is actually desmoplastic ameloblastoma, as I reported previously. The middle part is actually becomes like follicular and plexiform type. The posterior part is ameloblastic fibrosarcoma and ameloblastic carcinoma. So in one big tumor, it has 4 to 5 different types of ameloblastoma containing within. So I would say that it's like when you have the details of something, it's like not only one subtype can be seen in one big tumor. If you try to chop up the whole tumor, you will see different subtypes in one big tumor, and then you can sort of put the detail in your report. But it doesn't. I mean, it doesn't. Previously, I was taught that a follicular type might be more aggressive than plexiform type, might be more aggressive than desmoplastic type. But then these days, I don't believe that anymore. I believe that one big tumor can have so many histological subtypes which can occur altogether, but not every subtype, but some subtypes can occur altogether. So don't worry about that. If you see ameloblastoma, you treat it as it is. And then one big thing that you need to be concerned is that if the report comes out as ameloblastic carcinoma, you have to treat it differently. So if it turns out to be carcinoma, so yeah, you might have to do some neck dissection if there's some kind of swollen node or something like that.
Yes, yes. Thank you very much, Dr. Raji. You mean that in one tumor there is 4 diagnoses?
Yeah. No, not only just only that particular case or diagnosis. That's right. I would say it has features of I would say ameloblastoma, ameloblastic fibrosarcoma. There's and in brackets desmoplastic type, ameloblastoma, desmoplastic follicular and plexiform type, and ameloblastic fibrosarcoma, which is another entity.
And I want to ask you one more. For the pathological features, the microscopic, is it the same between the dental granuloma or cyst, oral cyst, and ameloblastoma?
Oh, so it's different because
it's different.
Okay. Sometimes it's difficult to differentiate. Not radicular cyst though. I would say the most problematic one is the dentigerous cyst, I guess, because if you see the lining of dentigerous cyst, it's usually the bilayer cuboidal cells. But if it's inflamed, it can become it can become stratified squamous epithelium. But sometimes it mimics the look of unicystic ameloblastoma. So you need to make sure that the area is quite right where you do the biopsy. And also with dentigerous cyst and ameloblastoma, you have to use the radiographic features of the limitation. I mean, like the well-circumscribed radiolucency has to be limited at CEJ in dentigerous cyst, but in unicystic ameloblastoma, which can occur histologically quite similar, it will extend down to the root surface. So usually with the biopsy, it depends on the site that you take and also the radiographic features as well in the cyst. I mean, like the point of view.
Okay, thank you very much, Dr. Aji.
Thank you, Andra.
I hope we can see you again in Surabaya.
I hope so. I would like to go to Surabaya very soon as they allow me to fly. Now I'm so bored.
Thank you, Dr. Andra. So I still have actually one last question.
Okay.
This one is interesting. It comes from Dr. Rossi. She asked about the red lesion, Dr. Aji.
Okay.
For red lesion, why usually it's having a higher risk to transform to malignancy if we compare to the white lesion.
Okay, let me show you. I cannot. I will show you this. Where is it? There's one thing. Let me finish the. I need to stop the share first and then go back to see. Just only less than. Just a moment. I show you the explanation. Oh, okay, here. So actually, why the red lesion appears to be more malignant than the rest? I mean, like the speckled leukoplakia or the pure white plaque. This diagram, it shows the development of the malignant transformation. It starts from the normal mucosa, which looks pink on the surface. After it becomes the leukoplakia. So leukoplakia can be homogeneous and non-homogeneous, right? Homogeneous one actually is thin, smooth leukoplakia, so it's flat. It doesn't have any feature. After a while, when the leukoplakia becomes thicker, it can have like feature in the middle, like this. And the more severe form of the white plaque, it will become verruciform, which looks like a hair or finger on the surface. So if you compare to tsunami, normal mucosa is just a very clear, clean sea. And then after a while, it will develop. After the tsunami occurs, the fissure will develop because the water will go down to the bottom of the sea, right? And in granular form, it's like when tsunami occurs. So the tsunami is like the verruciform or the finger-like projections from the superficial surface. Erythroleukoplakia or the red lesion, by its names, it's like when the tsunami disappears. After it ends, the red lesion is like when the tsunami removed the bottom of the sea, and it actually pushed the bottom of the sea up to the surface. You can imagine that, right? It's like when it has a crack down the bottom of the sea, lots of water will go down, and then after a while it will form a very big wave. But then after the big wave finished, it removed the surface of the sea, and then the red lesion, like that, it shows when the I mean the epithelial cells or the cancer cells from the epithelial area will push, I mean like they penetrate down to the deeper part of the connective tissue. So the red area is like the epithelial lining is very thin, or the epithelial lining, it moves downward to show more connective tissue up. So that means the red area shows severe form of dysplasia or the early form of superficial spreading of oral squamous cell carcinoma. So red area is bad because that means the epithelial surface will actually penetrate down to the connective tissue. And the second reason why white is better than red, because usually in the epithelial stratification, that means like when the epithelium is formed, it has 4 layers normally. The basal cell layer, stratum spinosum, stratum granulosum, stratum corneum. If it can produce keratin, that means the epithelium is allowed to grow all peacefully. That means like when the outer part, the outermost layer is the stratum corneum is the oldest layer of the epithelium. If the epithelium is allowed to grow old, that means like it's like an old man. He doesn't have enough energy to do things. So usually with the white lesion, lots of keratin, that means it's old. So the tendency to grow deep down to the connective tissue is less. But then if the epithelium, the superficial epithelium doesn't show any keratin, that means it's grow very fast and it doesn't produce the old layer of the epithelium. So it tends to move downward to the underlying connective tissue. So that's why we see red lesion is worse than white lesion because it doesn't grow old. It moves down to the connective tissue very easily. And then white lesion is better because it can grow old and it can create the stratum corneum, the thickness of the superficial surface of the epithelium. That's all.
Okay, thank you, Dr. Aji. It's very clear. Because I think many students are confused about this because the red lesion always have the higher risk transformation to malignancy. So I think your answer already explained about the question clearly. So I think we have covered all of the questions. So before wrapping up, Dr. Aji, do you have anything else you wanted to say?
Oh, I would like to thank the Universitas Airlangga for giving me such an opportunity to, give a lecture and also to discuss with you about all I know. I still feel that this particular topic needs more investigation in the near future because these days we don't know much. We know quite a lot, but not sure whether it's enough or not to cure the disease. So I would say take-home message today is about the early detection of the lesion. So first of all, if you can recognize the lesion, the OPMD, I think that's a very good way to fasten the investigation process and also the treatment process. So you can fasten it, so you can improve the quality of life of the patient, and you can increase the opportunity of the patient to get early treatment. So that's what I would like to emphasize, that you need to be able to recognize the lesions in the mouth, and then if possible, and if you can do the biopsy, or you can ask the colleagues in the oral surgery, you can have like Andra. So you can ask Dr. Andra to come and help with the biopsy. So it's easier to have a very strong connection to the operator, so to another department to help. So for the sake of the patient, to get a very fast treatment in time. I mean, before the lesion progresses.
So the sooner the better.
Yeah, that's right.
So I would like to thank for your kind attention. So also we deeply appreciate for Dr. Ajira for sharing your knowledge and also experience. May all those we have shared be beneficial for all of us. So thanks again for joining us today, and we will see you next time. Before this, I would like to ask for Dr. Aji and also the students for not leaving Zoom. So please wait in the Zoom meeting. And then I will return the lead to Dr. Ratna. Thank you very much.
Thank you very much.
Thank you, Dr. Ayu, and also Dr. Aji. Now I would like to invite our Dean, Dr. Agung Susiawan, to give certificate of appreciation to our speaker today, Dr. Aji. Please, Dr. Agung.
Okay, thank you, Dr. Ratna, for the time. Dr. Aji, thank you for sharing knowledge with us today. especially in oral medicine. And I hope we can invite you again with other scientific agendas, as well as other collaboration soon. So here is a certificate to you of our appreciation for your willingness to spare your time to giving us a lecture. Thank you once again, Dr. Aji. Nice to meet you.
Thank you very much, Dr. Agung, for your kind invitation and also your kind certification. Thank you so much.
And also we would like to give certificate of appreciation to our moderator today, Dr. Ayu. Once again, please, Dr. Agung.
Okay, thank you, Dr. Ratna. Thank you, Dr. Nurina, for being as a moderator for the last season of our Stovit online series today. Thank you, and see you in other session again in Stovit online series. Thank you once again, Dr. Nurina.
Yeah, thank you very much, Dr. Agung.
Yeah.
Now we would like to take a picture together with all participants. To all participants, please turn on your camera. Mungkin bisa dibantu.
Rosi mana nih Rosi?
Salah satu tim USI mungkin. Oke, saya ambil gambar dahulu ya. Untuk slide pertama, we have Dr. Aji, Dr. Agung, Dr. Ayu. 1, 2, 3, cheese. Oke, sorry. Oke, next slide.
Saka. Kalau Saka, Mbak Rizka.
And also the third slide. Ini sudah pada mati semua ya, anunya videonya ya. Tetap saya capture. Slide keempat. Oke, slide kelima. Ya, thank you all. And also thank you to our speaker today, Dr. Aji, and also our dean, Dr. Agung, Dr. Ruslin. Maybe we would like to have Dr. Agung for closing speech. Doctor, please.
Thank you for all the participants. I see Professor Safitri here and Dr. Henning as my senior lecturer. Thanks again for all the participants, particularly all the lecturer today in Stovit online series. I hope we can continue, we can meet and participate in other Stovit online series in the future in the other topics. And I think with interesting topic, I say thank you for the participation today, and nice to meet you. So, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Agung, for the closing statement. Ladies and gentlemen, on behalf of Stovit Online Series Committee here today, I would like to send my gratitude to our speakers for taking the time to share your knowledge to us, and also particularly to our from Faculty of Dental Medicine, Universitas Airlangga, and also Faculty of Dental Medicine, Universitas Hasanuddin. Last but not least, to all participants, thank you for joining this seminar. Hopefully, we will meet again in the future. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thanks, Dr. Aji.
Thank you.
Thank you very much.
Yeah.
Thank you, Dr. Aji. Dr. Aji, please, could you please still join the Zoom meeting, and also the student, Dr. Tricia, Dr. Kurt, and also Dr. Pema. We will take one more photo session. Okay, thank you very much for staying with us.
Bye, Aji. See you.
Bye.
Terima kasih, Dr. Andra.
Terima kasih. Thank you, Aji.
Thank you, Andra. See you.
Stay healthy and stay happy.
Okay.
Bye.
Bye, Andra.
Mas Ode, ini gimana? Di BR atau? Halo, Dr. Ode.
So we're going to have an oral medicine session now with all the other participants. So we can have Dr. Aji and his students for ourselves. Hello, Dr. Aji. Very nice to see you again.
Everyone is okay?
Everyone's great here.
That's
Yeah.
good.
Everyone's okay.
In Thailand, we just finished the second doses of the Sinovac.
Ah, yeah. So you got Sinovac there?
Yeah, yesterday.
Most of the medical personnel also get Sinovac, but now we also have Sinopharm and
That's good.
AstraZeneca.
Yeah, because the elderly here, they usually get AstraZeneca, but then
The elderly get AstraZeneca.
yeah,
I see.
But
It takes how long is the interval for between the first and
2
the
months, usually 2
2
months.
months? Okay. Here it's 3 months.
Oh, usually it's around 8 to 12 weeks. So it can be 3 months, but not over 3 months though.
No, yeah, because it depends on the study actually, but they say it's
Yeah.
up to 12 weeks. Yeah. Maybe because the response, the reaction is higher, it's stronger than the Sinovac.
I think so.
Mhm.
I hope that everything, I mean, like this pandemic will end very soon. I'm so bored.
Well,
I just want
that's-
to go traveling.
Yeah, I imagine so.
It's like, oh no.
But it doesn't end very soon. Eh?
But anyway, I think that the webinar is very convenient these days, and it depends on, like, it's sometimes it's very difficult to get participants' attention and also the concentration, because it's not like in the
The engagement is different, I
engagement
think,
is
with the
very
audience.
different. And then because our faculty hasn't fully open yet, we still need to wait until the 12th of July to open the clinic.
So the clinic has been closed all this time?
Yes, during this time, but then we're going to open the clinic very soon. So we follow the university schedule. So it will start on the 12th of July, but usually we open one month before the university schedule. But this year we cannot do that because of the we improve. I mean, like we are upgrading the ventilation system, so we haven't finished the whole. I mean, like project yet. We
Like
need to wait.
Preparing the negative pressure rooms.
Yeah.
Yeah. Okay.
So we will have a new clinic by the end of this month for about 50 dental chairs, and then in August we're going to have about 80 more. So overall, I think
So
then we
you
can
actually
perform.
wait until all the facility is ready and then you open it
No.
like that.